करता हूँ.
Okay, okay.
Good morning, everybody. We will
Joshi
start.
sir, Joshi sir,
Yes, yes.
we
हाँ बात कर लिए
এই ছবিটা যাচ্ছে
প্লিজ স্টার্ট
এই যাচ্ছে
Good morning, everybody who are watching. I will say, this is our annual conference, Sasicon 2021, organized by the West Bengal chapter of the Association of Surgeons of India. Will be held tomorrow and the day after tomorrow. And today is the pre-conference workshop, which is being telecasted throughout India. And I must thank as secretary of the association to the faculties and to the delegates, as well as our sponsor Alkem company, Pharmaceuticals Limited, who is basically projecting throughout the India. Now, on the start, we are going to start with laparoscopic cholecystectomy and welcome you all to this workshop. Now, may I request Dr. Saha to please place the case summary from the OT and start the surgery. Dr. Saha, please, can you hear me? Dr. Saha.
Yeah. Dr. Angshuman will give the summary of this patient.
Dr. Angshuman, please place the case summary.
This is a 60-year-old male patient presented in the outdoors with history of hyperacidity and flatulence for last 1 year. There was no history of any acute attack, for which he went an untucked sonography of the whole abdomen, which showed presence of three-walled gallbladder with a single stone of 20 mm. The patient does not have any other complaints. All the pre-op investigations were within normal limits. He is a known cause of COPD, diabetes, and hypertension.
Okay, so we will create neoperitoneum by Veris technique. So we make a while introducing berries, it is better that you just split this fat layer and made a small nick in the linea alba so that it will not touch the needle too much. So just a small nick in the linea alba. Finish all.
Dr. Saha,
Yes.
Are you usually routinely use this Veris technique,
Yes,
or sometimes
my
used?
practice is Veris. If you are confident in putting the Veris properly, it's safe.
Yes.
Gas on. Yeah. So initial insufficiency is a low rate. Is set to 3 liters per minute. Yeah, Striker 1588. 16. We are using a Striker 1688 imaging system with facility for ICG injection and being fluorescent in the bile duct. We'll show that the proper time.
Sir, in the meantime, please narrate the patient summary. Dr. Sahas,
Yeah,
can
he's
you
a 60-year gentleman
Yeah.
who has 1 year history of hyperacidity, flatulence, and mild abdominal discomfort. He has no episode of acute abdominal pain. He has no other comorbidity. And ultrasound revealed mildly thick wall gallbladder with a 20 calculus. So we are proceeding for lap cholecystectomy. We'll go by standard 4 ports, 2 10 millimeter and 2 5 millimeter ports. We started pneumo with varies and we set the pressure to 12 and initial flow rate to 3. We're getting gradually distended. We have reached 8 now. At a pressure of 10, you can go safely for putting the first trocar. But we have set to 12. We wait for pressure to go to 12. Yes.
Sir, will you please off your top light?
Yes, Dr.
Yes, it's now better.
Maji? So first you look at the site where you have made the Nemo. So this is a site. Slide bleeding from this point. Head and up. Yeah. Guys, no. Turn. Tick. the right of falciform, just close to the lower border of liver. Give me 10 millimeters stone forceps. Stone forceps, no. 10 millimeters. Oh, Rose Nichi. Rose Nichi. Spoon. So gallbladder appears clean. Okay. So next port is mid-clavicular port. I go little more laterally because if you take more medial port, it comes on the way of the camera. So it's better to have a little more lateral side. No, punta do. So while making these ports, it is better that you keep a support on the abdominal wall. Otherwise, when you try to put this port, even with a good Nemo, the abdomen goes much lower down. So it is better that you just keep a traction on the abdominal wall and direct this towards the gallbladder. So that is a way that your trocar will not touch the underlying viscera. One more. Nice. And anterior-axillary port at the level of umbilicus.
Sir, Sir, Dr. Maji, you please show the surface, abdominal surface once after completing the port.
Yes, Dr.
Show the
Maji.
abdominal surface once after completing the port.
Yeah. Outside the
Outside abdomen.
So this is the umbilical port,
Yes.
supraumbilical, epigastric, and
Yeah.
two 5 millimeter port on the lateral side.
Oh,
So this mid-lateral port is placed little more laterally,
yeah.
so that gives an ease of working.
Okay. Okay, sir.
Chalo, go ahead.
Please proceed, sir.
Hey, bipolar sila konta. Etai na? Chalo. So there are some additions. Yeah.
Sir, Dr. Maji here.
Yeah.
Sir, in this type of additions, working with only monopolar, how difficult it can be, sir?
Here also you can use a monopolar, but
Yeah.
this bipolar vessel sealer is a good option.
Okay.
That yes, you clean the cover. This creates a bloodless aerosolysis. You can use a monopolar here also. It's not a problem.
Okay.
Yeah, hold it. Follow me, your sister was from. Hold it. Hold. Oh. देखो. You see, we have given ICG. You can see the liver fluorescent. Gallbladder is having some fluorescence. You are not looking the bile duct because there is gross adhesion here. Okay. Yeah. This is a contrast mode. Okay. Still, you cannot see the bile duct because of the adhesions. Okay. Chalo. Normal. No.
नहीं लगेगा. So now you have to find the cystic duct here.
एक बार फ्लोरोसेंट देखो, फ्लोरोसेंट देखो एक बार। Yeah. You see, we can make out the gallbladder. Next, next. Yes, it.
Open microphone. Sir, your camera picture is not good, sir. Please adjust the color.
CVD कहाँ है फिर? दिखाओ, दिखाओ, दिखाओ।
Do the white balancing,
ठीक है,
sir.
बंद करो।
Yeah, that's good.
So see, we have now a critical view of safety. Okay. It's not necessary that you just sterilize the cystic artery. Some tissue around cystic artery is not a problem. So there are only two structures: the cystic duct and the cystic artery. And this is the liver, you can see. So this is a critical view of safety you should achieve before you clip. Okay. So you can
Sir,
now
just zoom a little bit.
yeah.
Sir, zoom a little bit.
Yeah. So you see,
And color adjustment.
yeah. Yes.
No.
So this is a cystic going to the bile duct. Okay. So we'll clip here. On normal color. So we'll clip the duct here. Clip the system. Clip.
Which camera actually you are using, sir?
This is Striker 1688 imaging system.
Okay.
Is the latest version of Striker camera, and it has facility for ICG also.
Okay.
Caesar. Yeah, you can see the bile duct down.
Yes. Yes.
Okay.
Can
Yeah.
be seen.
As I said, it did not completely sclerize the artery. Some tissue around the artery is not a problem because they are applying LT 300 clips. তাতে স্যার আমাকে ওয়ার্নিং দিয়ে গেছে, সি করা যাবে না, সি করা যাবে না। এবার সিল করে যাবে। In fact, you have a good bipolar sealing system. Actually, my practice is I just buzz the cystic artery. It seals very well.
Okay.
This
Can the cystic duct also be sealed without using
no,
clip?
cystic duct you have to apply a clip because cystic duct will not seal completely the bipolar. No.
Okay. Okay.
Caesar. Now, taking the gallbladder off from the bed, you can use either a monopolar,
Yes.
but I prefer to use this bipolar sealing system,
Okay.
which takes the gallbladder very well from the bed.
Yes. Yes.
It is better to keep a rim of peritoneum towards the bed. It's not wise to go to the junction of the peritoneum and the liver. So you have less bleeding. Just keep a rim of peritoneum towards the bed. And then work in this loose alveolar plane. One should not go deep into the liver bed.
Perfect translation.
Huh?
Perfect translation.
I know. Wow, that's good. The monopolar is faster, but if you use a bipolar, you will not see that there is any of the oozing from the size you are going through.
Definitely bipolar will seal well better than monopolar, isn't it? The sealing definitely will be better in bipolar.
So that's what I'm saying, that you keep a leaf of peritoneum
Yeah.
towards the bed
Okay.
so that they don't go to the junction.
Yes.
And these fine vessels can be easily sealed. You can use a monopolar, but I prefer this device for even taking the gallbladder from the bed. And if you leave behind this loose tissue towards the liver, the bleeding is minimal. I am worried about the size of the stone. With a 2 centimeter stone, I have to take out through this small opening. The stone has to be oriented.
From which port usually you extract the gallbladder, sir?
Yes,
Through which port you usually extract the gallbladder?
I use the epigastric port, but Dr. Tatia is fond of taking his gallbladder out to the umbilical port.
Oh.
Both are acceptable, yes. But I
Oh.
use the endo bag for this.
Is there any difference between these two?
Yes.
Is there any difference between these two?
No, no.
Okay.
Umbilical port is easily stretchable.
According to surgeon's convenience, you can extract it to the epigastric gallbladder.
Sir, collar mic. Collar mic. Sir, mic is আমার ফোনটাকে অফ করো। এটা অন করছিস কেন? অফ করতে?
If in the right
Sir,
leg,
আপনি আবার on
you have
করতে
no bleeding to the issue. It has to be bloodless deficient of the liver bed.
Absolutely bloodless. Excellent, sir.
Endo bag দাও sister. আমার transparent bag দাও। হ্যাঁ, good body. Bipolar sealer. এটা তো আমি ইউজ করি, আমি তো সিসি কাটারি ইউডি দিই এটা দিয়ে। Bipolar sealer. You see the bed? আমার তো লোকাল বেড। ओरे देरी भैया, हम डर गया था भाई, तुमने मेल पेशेंट लगा दिया।
बहुत बढ़िया वेरी नाइस।
Come on, sister down. पूरी इतना बड़ा ले लिया, हमारा बैग का है, हमारा আছে তো, এত বড় ঢোকাবো, বড় না কাচি দাও। ধরো রিভিশন দাও, রিভিশন। হ্যাঁ ঠান্ডা।
Dr. Saha,
Yes.
are you going to use any drain?
No.
Probably no.
No. I don't use routinely drain. This is this patient. We have a nice dissection of the callots.
Yeah.
We have nice the liver bed. So there is no reason to put a drain. So drain is not routine for all patients. You can
Yes.
avoid drain. I use drain if you have a very wide cystic duct and you
Yeah.
have a difficulty in dissecting from the bed and gallbladder is partly intrahepatic. In that case, even if you do a good job of separating, there might be minor leak from the bed.
It should not be routine nowadays.
No, no, no.
Okay.
It's not mandatory that you put drain in gallbladder surgery.
Thank you,
If you
sir.
have a clean dissection in this manner, you
Yeah.
may avoid putting a drain.
Okay, sir.
Very well, very well.
And use of this bag is routine for you, sir?
Yeah, yes. I always use a bag because we had very bad experience of previous port infections.
Yeah.
And now we use a bag with good autoclaving of the instruments. And here in ILS, we are all using ETO sterilized instruments. So there is virtually zero infection rate. Good. Yes. Hold it. Hold my left hand. Hold my left hand. So for extraction, I don't use a crocodile forceps. I just use a direct coppers. Give me a coppers.
Sir, you should publish this,
Long
sir.
coppers.
Using this sterile bag, if it actually prevent the
You
infection.
can just use a coppers and hold the gallbladder with the bag.
Yeah.
And then bring it up. Top right. Oh yeah. Okay. So yeah, it's out.
So gallbladder is out. Sir, how you are going to close the ports?
You see, my practice is I always just put a single layer stitch,
Okay.
taking one bite in the sheet.
Yeah.
But other standard recommendation that you close the first layer separately with a 20 Vicryl, but a single layer closure is good enough. I have no repetition.
For both the epigastric and umbilical.
Yeah, yeah. Single layer.
Ah.
Take a deep bite so
Yeah.
that the sheath comes in the stitch. So
It's a blind bite or under vision?
Yeah, yeah.
It's a under vision bite, sir?
You see, the epigastric port, if you take a deep bite, the anterior sheath easily comes. It did not take the posterior sheath.
Okay.
Saccharon.
So this procedure is almost at the end.
Yeah.
And we are going to switch to our next OT, which is also a laparoscopic cholecystectomy to be done by Professor Tomanas Chaudhary, sir.
So you can pass to the next OT.
Yes,
Either
yes,
we'll
yes.
start a thyroid
Yes, we
or,
are proceeding.
or we'll
Yes,
the breast.
yes, we are proceeding. Dr. Chaudhary, Dr. Tomanas Chaudhary, Dr. Chaudhary, sir, can you hear me? Dr. Chaudhary, can you hear me?
আরে আমার মাইকটা অন কর নাহলে আমি কি করে শুনবো আমি চিৎকার করবো
Patient সোজা করো। মনে করে দেবো।
Dr. Chaudhary, can you hear me?
অভিরাম আমি তোর কথা শুনতে পাচ্ছি কিন্তু তুই আমার কথা শুনতে পাবি না
আমার কথা শুনতে পাচ্ছি না তো।
এই তোমার অডিও লুক হ্যালো
হ্যাঁ, can you hear me, sir?
yeah now I can hear you
Okay, you can start, sir.
good morning Professor Maji, welcome to ILS Hospital for Sasicon 2021 and truly in these pandemic situation this is a real pleasure to meet friends though it's a virtual we cannot meet all our friends but at least some of you are coming in our hospital and welcome to this virtual workshop. So this patient is suffered from gallstone pancreatitis last week. After settling down the acute pancreatitis due to gallstone, we have planned to do laparoscopic cholecystectomy. So we'll put the standard 4-port lap chole. Already we are after putting all ports, we'll show you the port positions. Are already Professor Saha described the port positions.
Yes, yes. There is one there.
Infraumbilical 10 millimeter port for visual. There is one epigastric port for right hand working port and mid clavicular line right is for left hand working port.
Sir, one question.
Please.
After how long after the resolution of the acute pancreatitis you are doing this surgery, sir?
Basically, our policy is the patient will go after settling down the pancreatitis.
Yes.
Patient will go home without gallbladder.
Okay.
Patient will basically in same hospital sitting.
Okay.
We always do the lap cole.
Okay.
Except if the patient is really not withstand the anesthesia, but even then we always try to do the lap cole in the same hospital admission.
Okay.
After settling down the pancreatitis. So always our dictum is after acute gallstone pancreatitis,
Yeah.
patient will go home without gallbladder. So now we are taking the
Gallbladder out.
So there is some additions. We'll do it.
Yeah.
When before we remove the. So now you know that we'll divide these additions. We are fortunate enough. This is very unexpected additions, which were not determined before. So we'll do this.
Yes.
So we'll do this additional lysis for our easy access.
See, I am handing over the mic to Ramanuj. Okay. Sir, can you hear me?
Yes,
Ramanuj is super conductive.
Ramanuj.
Yeah.
Okay, welcome, Professor Mukherjee.
Yeah. Dr. Professor
We are
is
doing
in.
additional lysis, and in truly, you know that
Hi, good morning, everyone.
when we talk about our ergonomics, now you can feel basically what happened. Our monitor is other side in the right shoulder. We are working at umbilicus, and there is absolutely that is called parallax. We are working. The hand instrument is parallel to camera, but working. The organ is absolutely right angle to the working monitor. So that challenge we are taking. So we are just as such we do it. Rest we will do afterwards. Now we finish the surgery first. Please come on.
Hello.
Yes.
Sir, very good morning, Ramanuj here.
Yeah, Ramanuj.
Okay. Sir, by the time, sir, the ports are being made, and yes, sir, we have a beautiful view of the upper abdomen. Yes, sir, beautiful view.
I can't get you. Camera outside. Clean. Please.
Sir,
Outside. Yeah, Ramanuj, bolo.
Sir, by the time we have the ports in place, sir, fogging is a real nasty problem that sometimes we face. Sir, what are your
Louder
tips
voice,
to avoid
please.
fogging?
Slightly louder voice. Sound. I can't hear you, Ramanuj.
Sir, am I audible now?
Now you are audible. Please.
Okay. Sir, what are your tips to avoid fogging? Because
now you are audible. Please.
yes, sir. Sir, any tips to avoid fogging? Fogging of the lens.
Anything?
Tips to avoid fogging. Fogging of the lens.
Okay. So what we do? Please show me the thermoflask. Thermoflask. I am showing you a camera to this. So this is basically a Milton. I think it's a 500 ml thermoflask. We always keep, and it is a sterile. It is autoclaved, and we put a normal saline, and deep into it we always put a camera. So we always put a gauge piece, because when we put the lens, it never hit the bottom.
Exactly, sir.
So there is a gauge piece. So we hit it before we put the camera inside. So that's the always we. This is a part of our instrument set.
I think
We can use it. Sometimes this is very simple. And apart from these, we can use we can use povidone and iodine
Right.
solutions. There is earlier Karl Storz have one solutions,
Okay. Right.
anti-fog solutions.
But I think, sir, this is a very
Yes, sir.
simple innovation and very useful.
Anti-fog solutions, but truly I don't have any experience of using that anti-fog solutions. But these thermoflux is really, really always we use it. So in a standard port positions of 4, our assistant in from anterior X-ray line,
Right.
he will hold the fundus and we will push the gallbladder towards the right shoulder.
Right.
So this is like this. And as such, we plan that we will go for energy source as a harmonic scalpel. I'll show you the both. So that is
Sir, I think your camera surgeon is doing excellent job. Sir, who is at the camera?
in my left hand side as in camera, Dr. Umsuman Poddar.
Okay, Umsuman, good job.
Umsuman. So I am using monopolar as a energy source, and Ramanuj, you can appreciate that always we put
Right.
the traction laterally,
Right, sir.
and just by touching we can divide the additions. And the same thing I'll show you by another energy source, that is harmonic scalpel. Footplate change. This is just for, because this is a demonstration. Like this cholecystectomy never use harmonic as an energy source. We always do by monopolar, but we have a luxury in a workshop of
Sir, I
using
think,
the
sir,
harmonic.
this is the best way to use a
And
harmonic.
why I am using this harmonic to demonstrate my working blade. This is the two blades. One is working, and this is active and passive. This active blade, I am always trying to keep it under vision and above, so that it will not injure anything. If I use like this, so this is the duodenum.
Exactly.
And always remember, this working blade is very heated, so that should not be touched in any organ.
Exactly, sir. Very well point made. I
So
think,
that-
sir, we go by the mnemonic A is A. Active is above.
Yes, active is perfect. So this is
Sir, beautiful demonstration of the sulcus of Rouvier.
yes.
Both of
So
you,
this
beautiful
is
demonstration.
this is the Rouvier sulcus. So we'll let some more dissections will allow us to reach there. Hartsman is up to these. I can feel the stone here.
Yes.
This is the additions. And the dictum is we should not go below Rouvier's sulcus.
Absolutely.
We should not dissect below Rouvier's sulcus. So
Absolutely.
this is the Rouvier's sulcus. So our dissection line will be above that.
Absolutely, sir.
Above that.
Sir, I think it's a beautiful demonstration of posterior first, and then we go to the anterior. Beautiful demonstration. Sir, I have with me Dr. Anuj Poddar with Anuj. Welcome.
Okay.
Good morning,
Anuj,
Dr.
welcome.
Chaudhary.
Welcome, Anuj.
There is a small tips or question I can
Yeah,
ask
please.
you. To avoid slipping the stone in the CBD, what is your tips? Sometimes it's good if it is multiple stone, and
To
it may
prevent
slip
slippage
into
of stone in CBD,
Hmm.
truly if in CBD cystic duct diameter is too big, truly it's very difficult to predict if the some stone is not already into the CBD. I hope by this small manipulation it cannot be.
No,
So
it,
always
it's
we are holding
happens
the
with
Hartsman
me.
pouch.
Hmm.
This is now for our PGs and juniors. I must demonstrate one anatomical locations. First, Ramanuj rightly pointed out the Rouvier sulcus. So we should not dissect below this line. This is a CBD. If we give pressure from there, it is a CBD. I am giving pressure from there, and we can feel this is the CBD here. So above this line, we should dissect. This is one. Now, if you look the anatomy below this liver surface with the common hepatic duct and the cystic duct. This is a cystic duct. So this is cholecystohepatic triangle. And in this cholecystohepatic triangle lies the Callo's triangle.
Right.
And somewhere here the cystic artery, and this is cystic duct with a common hepatic duct. This forms the angle. This is the Callo's triangle.
Right.
So anything we dissect loose areolar tissue in this triangle should be very cautious. So always we do a very good complementary anterior dissection, but we will go for a posterior dissection.
Absolutely, sir. And all the
Footplate
viewers of this video must understand that
footplate.
you have picked up the peritoneum very nicely at the posterior.
So
and then
but so basically we are very monopolar. We are very comfortable with monopolar. That's why I'm just for a small segment I am dissecting with harmonic. But usually what we do, that will demonstrate. So this is our instrument for left polar. Always we use this. With a small tissue.
Right.
And
sir,
the
I think
tip
that we
is,
should use always a
after
spectrum
putting
of
the
energy
tip,
source. Right.
After putting tip, we just slide slightly. The CO2 will go between the tissue cell and we just take it out. Like this.
Exactly.
One movement, CO2 will go in and that will make our dissection path.
Exactly, sir. Very good demonstration. Traction,
And
counter traction.
always we have a wide posterior dissection.
Exactly, sir.
Why?
So this is something
We
that
never
I learned
hesitate
from you, sir.
For any posterior dissection.
Right, sir. So
We
this
have
is
a
something
wide
that I have
posterior
learned from you.
dissections.
A wide posterior is something, sir, that I have
Yes.
learned from you, sir.
Again, we back. So there is a small vessel. We check.
No. Still, Anuja, what sir is showing is the ideal lap cooling. And I think that whenever, even if it is a fibrotic contracted gallbladder, you should always strive to do this step. It makes the rest of the
So
life
this is
of
the
the
plane.
surgeon very easy.
Yeah, Ramanaj.
This is something.
I have an experience that stone is slipped into just confluence of the cystic duct and CBD in the junction, and it is so impacted we could not remove that thing.
No, I can't get you. What, Anuj? Please repeat.
And a stone slipped into the cystic CBD, but not CBD. It is in the junction, and it is impacted there.
Yes.
It is so hard we could not remove that time.
We are so there is a stone which impacted in the cystic duct. Can you see that we have created the window from posterior itself? Can you say it? The window is created. From anterior, if you look, the already window is created.
Right.
That's it.
Sir, I think that, sir, the hook is a beautiful, versatile device to create a window.
Yeah. So
And the mastery of the hook is something that needs to be learned.
And for Anuj's question, that stone impacted in the cystic duct,
yes, sir.
it happens in number of times. The stone impacted at the Hartmann pouch. That is basically cystic duct. So in that case, sometimes even we have to cut the cystic duct, keeping a small portion, we squeeze it out and then we put the clips.
Right.
Because we are not getting enough space to clip below the stone. So that sometimes we have to cut it, check it, then we put the clips. So we'll do some more posterior dissection.
Right.
So whenever any difficulty in lap cole, anything, we go for posterior dissection.
Sir, I think, sir, this is a message that everyone should understand. A beautiful wide posterior dissection,
Yes.
sir, technically dissects and demonstrates every aberrant anomaly in this area.
Yes, yes.
All
Absolutely.
the right posterior sectoral ducts, all the aberrant, the double cystic artery.
Absolutely. Basically,
Yes, sir.
we always follow the
This is a beautiful critical
view of safety, and we will go for a timeout before clipping.
Exactly. So this is exactly the steps to avoid and bile duct
So
injury, and this is the timeout.
if we talk about critical view of safety, there is a 3 components in critical view of safety. Number 1, we should dissect in the callocystohepatic triangle,
Right,
and at least 1/3 of the cystic plate should be dissected. So this is one
Sir,
more
can
than
you
this.
again show the cystic plate to all viewers?
This is cystic plate.
Okay.
So almost 1/3 we have dissected.
Right, sir. Beautifully shown.
Gallbladder should be lifted from the cystic plate at least 1/3. This is one. There will be two and only two structures connecting with the gallbladder. Two and only two. Nothing more. So this is number 2.
Right, sir.
And number 3, the same thing we can visualize from both the ends.
Exactly, sir.
This is flag movement from
Right.
both. Nothing more.
This is the doublet view and
Doublet view.
very
Yes, doublet view.
very beautifully shown, sir. Beautifully
So
shown.
this
And I
is-
think everyone is starting a lab coli
And
must appreciate this beautiful dissection that has been done.
so now it's ready for clipping. Now I am slightly doubt. This is it accommodate 300 LT 300? If we have any doubt, because this patient have a past history of acute pancreatitis, so what we do? In that case, we'll put a legal clip. If it's because it's slightly wider.
Okay. Sir,
So
we
I'll
are
check
just-
with a. I'll check with.
Sir, Kamana sir, we are just muting you because we are going to the OT2 with the bariatric. Sir, your video will go on.
Sure, sure,
Okay,
sure.
sir, we'll shift off the sound to this.
Sure, sure.
Nathia sir, very good morning, sir. Ramanuj here.
Very good morning, Ramanuj. How are you? Good morning, viewers.
Good morning, sir. Your sound.
My name is Dr. Om Tandia. I welcome you all to ILS Hospital, Kolkata. Mic on kar rahe?
Sir, you are audible, sir.
Okay.
Sir,
So I welcome you all to ILS Hospital, Salt
Okay.
Lake, Kolkata, in this wonderful Sasicon workshop. The patient that we have taken is a 56-year-old male. Patient's weight is 130.1 kg. Patient is diabetic. Patient is hypertensive, and patient is having severe sleep apnea. Patient doesn't have osteoarthritis. So we have decided to do a bariatric surgery, mini gastric bypass on this patient. Okay, the patient, now I tell you about the patient position. The patient is in supine position and he's properly strapped to the OT table so that he doesn't fall. Patient is in a steep head up position, about 45-degree head up, and a great deal of left side up, almost 20-degree left side up position, left side up arrow correctu. So this is the position. I tell you outside picture. Can you see outside picture?
Sir, can that PIP be done? Can
Outside picture?
right,
I
can
show you the port positions first.
Can you show the port position? Outside picture, please.
Outside picture.
Yes, sir.
Are you
Sir,
getting?
Yes, sir. We are
So
getting that.
this is, can you see my finger?
Right, sir.
This is my optical port. This is about 18 centimeter below the xiphoid process. We do not take into consideration umbilicus in a bariatric patient because the position of the umbilicus is variable. So what we take is a bony landmark as the referral point. So xiphoid process is the referral point. Ulto. Bus. Xiphoid process is the landmark. 18 centimeter below the xiphoid process is my optical port, 12 millimeter. My one left working port, that is my left hand working port, is in the epigastric region, subxiphoid about 2 centimeter below the xiphoid process. My right hand working port is in the right mid-clavicular line in between these two ports. In between these two ports in the right mid-clavicular line. All these three ports are 12 millimeter. Another 12 millimeter port is in the left mid-clavicular line, bang opposite to this right side port. One port, 5 millimeter, is used for retraction. Now, you have seen me taking a piece of omentum.
Yes, sir.
This is for our study purpose. We are conducting a study with with Molecular Biology, Institute of Molecular Biology. So for diabetic patients. Now, the first thing that we do is, see, this is the crow's foot. Can you see?
Yes.
This is the crow's foot. This is the crow's foot, and this is the pylorus. Can you see the pylorus?
Yes, sir. We can see the pylorus.
Yeah, this is the pylorus. So anywhere between the crow's foot and the pylorus, we take a point to enter into the lesser sac from the lesser side, curvature side. From the lesser curvature side, we enter into the lesser sac anywhere between the crow's foot and the pylorus. The normal preferred position is about 3 to 4 centimeter proximal to the pylorus. So I've lifted the omentum, gastrohepatic omentum, and trying to divide it so that I gain a access into the lesser sac. So you can watch me mute now, and you can go back to the Lapcoli position.
Right, sir. Sir, will be, sir, switching off your audio.
You can just watch me mute and see what I'm doing. I'll explain once you are back with me.
Okay, sir. Yes. Kamanas, sir, we are back with you.
Okay. Already we have packed the gallbladder in the bag. Now this is the final picture.
Right.
So what we basically
Sir, can I have the full
demonstrate-
screen? Yes, sir.
This is the final picture. So one comment regarding cystic duct. The moment cystic duct is clipped, it will throb. Okay,
Right, sir.
this will throb. So this will prove this is a cystic artery. Whenever we clip the cystic artery, this will throb. Before that, it never.
Sir,
Anything
when
that-
do you consider ligating the cystic duct and when to give a 400 clip? Because I have seen many people use series of 400.
No. Normally, for proximal clips like these two LT300, we put LT400 this side. What we do, we put liga clips. That is vascular clips basically, but that really holds.
Okay.
If beyond that,
Right.
then always either we can put a ligature or we can cut and suture. That is better than put a incomplete clipping. So
Right,
this
sir.
is cystic duct.
Sir, I think that's a very good advice because if you have a hemolock,
Yes.
hemolock is a very good clip, but if you don't have, I think it's good to suture.
Yes, suture or you can put a endo loop
Right, sir.
sometimes. So this is the final view of the surgery.
Beautiful
Okay?
view, sir. Sir, are you going to give a drain? I don't think so.
No. We never put a
Less
drain
than
now.
5 ml blood loss maybe.
No. We do not put a drain. And we should not forget to remove these gauze paste
Yes.
before we do. After that,
Sir, we are switching off the audio
Yeah.
to OP2.
Yeah, Ramanus,
Yes, sir. Sir, good morning again.
I've created a window in the,
Can I have the inside view, please?
yeah.
Right. Yes, sir.
Can you see I've created a window now
Yes, sir.
to gain access into the lesser sac? That is the lesser sac.
Yes, sir.
Now my step is I pass a stapler from the subxiphoid port, a 45 millimeter gold cartridge, 45 millimeter gold cartridge coming from the subxiphoid port to put Tabarkor.
So the subxiphoid port then is always a 12 millimeter port.
12 millimeter. All these ports
Huh.
have to be 12 millimeter because stapler is coming from these ports.
Right. Sir, any particular tricks to avoid any vascular abnormalities in this area? Because you are operating in the pars flaccida, I think.
Yeah. See, the trick is we stay close to the stomach.
Okay.
That is the basic trick. It is absolutely perigastric. So, Ramanuj,
Yes, sir.
I've engaged. I've engaged the 45 millimeter load, and this stapling is between the crow's foot and the pylorus. You can see the pylorus here.
Yes,
Can
sir.
you see the pylorus?
Yes, we can see that.
So, and that is the crow's foot. So between the crow's foot and the pylorus, I am making this stapling, the 45 millimeter gold load. And I must make sure that there is enough space between the greater curvature and the rest of the antrum so
Right.
that the gastric juice can go down into the duodenum.
Sir, I think that's a very valuable because you should see the tip of the device.
एक बार इधर देख.
Because sir, momentum, yes sir.
I think there is enough space.
Yes sir, there is enough space, sir.
So that the gastric juice can go into the duodenum. So now I wait for 30 seconds for a good compression before I fire my stapler. I'm using a gold load echelon stapler from Johnson & Johnson Ethicon. Here I'm using a gold load because antrum is a thick structure. So then I fire the stapler and that's it. The next thing I do is I see whether there is any adhesion between the posterior wall of the stomach and.
Sir, in a case of a staple line bleed at this point,
Yeah.
sir, how do you tackle that? Do you use a diathermy?
No, never. Never use any energy on the staple line bleed. Never. What we have to do is we have to suture. Either we suture or we put a clip, anything, but never any energy, because it will cause burn, it may cause leak in the post-operative period.
Right.
Now I make horizontal firing. This stapler is coming from my right mid-clavicular port. Again, a yellow load, gold load, and
Sir, this is again the gold cartridge load, I think.
sorry,
Again, sir, this is again the gold cartridge.
gold, yes,
Right.
gold. This is a gold cartridge, and it has to engage properly here at this angle.
Right.
See, one thing, Ramanuj, here, this is the crow's foot, and this is the incisura angularis.
Right.
छोड़ दे उसको, liver छोड़ दे. This is the area which has got a highest tendency of stricture or stenosis. So we have to be liberal on this area. We have to be well away from the point of insertion of these vessels into the gastric wall. Okay.
Absolutely.
So I am firing.
Sir, what is the length of the staple line? I think 60 millimeter.
This is 60 millimeter.
60 millimeter.
This is 60 millimeter. So there are adhesions on the posterior wall. It's got a. No, ये loose. See, these loose staples must be removed at all times. Otherwise, they may get stuck into the gun
Right.
and may cause misfiring of the staple.
Yes, sir.
There are some adhesions in the posterior wall of the stomach, and there are a lot of fat. I have to, ये area clean है क्या? Yeah, this area is clean. Solid. So next, I will make a 30 millimeter, 60 mm blue load. And the length of this entire gastric tube
Yes,
is
sir.
somewhere between 20 to 22 centimeter, starting from OG junction to this final division. Ramanuj, a point of caution to all the people who are going to start bariatric surgery is that at all time we have to avoid any twist, and the twist can be avoided only if when we fire anterior and posterior wall are taken to the same proportion. If by mistake we take more of anterior wall, which is a common mistake, then there will be a twist. So we have to avoid twist at all costs. Okay.
Right, sir. That's a good tip.
Yeah. Now we, you see, I'm going almost parallel to the lesser curvature, and
So this is a blue cartridge.
this is a blue cartridge now, because I'm in the body of the stomach, which is a thin part. Now all the way up to the fundus or OG junction, it will be a blue cartridge. it's a good practice to wait for 30 seconds before we fire the stapler. This gives a very good hemostasis. Now I will ask my anesthesiologist to advance the bougie. We are using a 36 French bougie. इसको दिखा, इधर वाला end दिखा. Yeah. We are using a 36 French bougie. My anesthesiologist is now advancing the bougie. Bougie, yes. So you can see the bougie has now come into this gastric tube. Can you see the bougie coming into the gastric tube? Can you see this?
Right, sir. How to prevent the bougie from entering the lower tube or the stomach tube?
I see. Did you notice that I
Yes.
had advanced my stapler
Right.
so that this guides the bougie into the position?
And sir, how do you determine the size, or how does the anesthesiologist determine the size of the bougie?
See, it's a standard size 36 French bougie. All the procedures we take this size. इसी से आ जाए, इससे आ जाए. So 36 French, and this is the only bougie which is available in our country.
Okay, sir.
So again, we have to take a 60 centimeter blue load, and this time now I'll be going close to the bougie all the way up to the OG junction. See, Ramanuji, initially, mini gastric bypass or OAGB1 anastomosis gastric bypass had fallen into disrepute.
Right.
The reason being, this procedure was first described, or one anastomosis gastric bypass was first described way back by Edward Mason. And what Mason had done, he had divided the stomach almost close to the OG junction, and he had created a loop anastomosis close to the OG junction, which is not a good thing. If you have to create a loop anastomosis, the tube has to be very long.
Right.
Because this mini gastric bypass is based upon two principles. The principle of Billroth 2 and Coley's gastroplasty. Billroth 2, we have a loop anastomosis well away from the OG junction.
Absolutely, sir.
Okay. And Coley's gastroplasty is extension of the esophagus, so it is basically an extension of the esophagus with a Billroth 2 type of anastomosis.
Sir, I think, sir, you are going gradually towards the fundus and the upper part of the body.
Yes.
Sir, at this point, sir, does a short gastric need any mobilization?
No, short gastrics do not need any mobilization because I am well away from the short gastric. I am on the stomach. Greater curvature greater curvature. हाँ बस बस ওটা ধরে টানতে হবে তোমাকে এখানে ফোল্ডিং হয়ে আছে হ্যাঁ ঠিক পারফেক্ট এবার এটা দিয়ে আসবো এটাতে দিয়ে দে Now my next firing comes from my left hypochondrial port. The next firing is coming from liver tract. Boss. Yeah. Left hypochondrial port. ठीक. So I've engaged the stapler, wait for 30 seconds, and একটু বুঝিটা একটু withdraw. হ্যাঁ ঠিক আছে
Sir, these are powered staplers, I think.
These are powered staplers. খোল এটা। Yes. তোলো বস। রোটেট করতে হবে। window bar. Now I will create a window here
Right, sir.
so that my stapler can engage nicely.
So, ladies and gentlemen, as we prepare for the thyroidectomy
I will withdraw
on
with
another table,
stapler or marker.
and for the mammoplasty on another table to be started by Professor Makhal Lalsa and Professor Devchandra Sarkar respectively. Sir, beautiful dissection, sir.
Yeah.
Less than 5 ml blood loss, maybe. Beautiful dissection.
There.
So the liver retractor is a gold finger?
Liver retractor is simply a needle holder.
Okay, right. So do you need a gold finger or?
We may need a gold finger.
Okay.
Withdraw. एक बार withdraw. हाँ करूँगा. पहले एक ये फायर कर देता हूँ, फिर उसके बाद करूँगा. एक फायर कर लेते हैं ना. अच्छा देखिए. एक फायर कर लेता हूँ, मेरे को जगह मिलेगी. हाँ, स्टेपलर. हाँ नहीं लेता हूँ उसको. पॉजिटिव वाटर धोरे टानते हुए बहुत. पॉजिटिव वाटर धोरे टाना एक. ধরে আরেকটু টানতে হবে. পজিটিভ ওয়ালটা. স্টেপল লাইনটা ঠিক করো. ধরে টানো. হ্যাঁ এবার ঠিক আছে. পজিটিভ ওয়ালটা पॉजिटिव नेक्स्ट उसमें आएगा. धोरे टानो. ठीक. ऊपर से दिखा. ऊपर से दिखा.
3D তে পারসেপশনটা ডেপথ পারসেপশনটা বেটার হবে. দুর্দান্ত ডেপথ পারসেপশন আছে.
দাঁড়া বুঝি কোথায়. ছাড় একবার. रिलीज को. आर्टिकुलेशन कम कर दिया. এবার তুমি নাও এটা. টানো. হ্যাঁ এবার ঠিক আছে. দিস ওকে. So after that, we will enlarge the window and we may have to lyse the adhesions between the fundus and the diaphragm here in this part.
Right.
So,
Sir, while you take that, sir, is there any chance of the boogie to get caught by the staple line?
sorry,
Sir, is there any chance for the boogie to get caught on the staple line?
no, bougie is so big that it can never get caught into the staple line. The staple will never close. If it is a rise tube, it can get caught, but no, bougie can never, because bougie is so big that it can never get caught. रुको बॉस, रुके जाओ. Now I'm creating this window.
Right.
ওকে, একটু উপর থেকে আসি, উপর থেকে, হ্যাঁ, ইয়া, তুমি এটাকে ধরো, এখানে ধরো, হ্যাঁ, patient is having a lot of fat in this area.
Right, sir.
Sorrow.
Sir, what is the position of the patient is anti-Trendelenburg, I think.
Sorry?
So the position of the patient is anti-Trendelenburg.
Yeah, steep head up.
Okay.
ওটাকে ধরে একটু টেনে নাও বস, ফ্যাটটাকে ধরে একটু টেনে নাও, বাস বাস, পারফেক্ট. Steep head up and left side up, because I'm standing on the right side of the patient. So if I make the patient left side up, all the ports, they come very close to me. All the ports, they come very close to me. And it's a very voluminous stomach. You can see that.
Yes, sir.
Yes, yes. এটাতে, হ্যাঁ, বাস 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 বাস. I think I'll fire one more stapler so that it will open like a book to me. Yeah. There. Huh? Huh. There. এখন একটু রেস্ট পেয়ে গেল. না, সে জানি আমি. কাজ শেষ হ্যাঁ, মোহিতের বা মাখনদা, মোহিত মাখনদার মতো. I had put it the other way. You can see so much fat. এই পোর্টটা একটু ঢোকাতে হবে. पोट्टा एकटू ढोका हाँ
Sir, this area particularly appears to be very dangerous because you have the diaphragm and you have the cranoesophageal ligaments, I think.
Okay, so we have created the window.
Okay.
There. It's a very long, very big stomach and a very voluminous stomach.
Absolutely, sir.
Doretano. Doretano. Fat সরিয়ে দাও বস ফ্যাট যেন স্টেপলারে না থাকে তো ফ্যাট তো গো डाउन हाँ ठीक है फायर कर दूं शशि फायर कर दूं so complete
sir.
Ramanuj complete
Yes sir.
Okay, so
beautifully dissected. That area particularly was very tricky.
Now it's a long tube and it's a big tube. This is in contrast to what we have in sleeve gastrectomy, where we have a narrow tube.
Absolutely.
So it's a big tube and it's a long tube. A ghost about I barcode which I barcode. Now the next step is gastrojejunostomy. For that purpose, tube tag to withdraw. The first thing I will do is I will remove the fat on the posterior wall of the stomach tube because the anastomosis will be posterior. I don't want any fat in between the anastomosis.
Right, sir, and the vascularity of the stomach more or less can allow you to do that very safely.
Yeah,
because it's not the Roux-en-Y limb where vascularity will be a concern. Stomach is a very good vascular organ, so that you can strip up. Sir, what is the distance from the staple line that you plan to do the anastomosis?
I'll show you. It will cut through the staple line.
Okay.
Could I? So the bleeding has stopped. So take it. No bleed, huh? No bleed. Now we will make a now we will make a gastrotomy. Here we have to be very careful. What I am holding, this is the medial end, and what Dr. Chaudhary is holding is the lateral end of the stomach tube. Now he will push the bougie, and I will make the gastrotomy here in between the medial and the lateral end.
Sir, I think that the orientation is very important.
Orientation is very important. Very rightly said Ramanuj. then you can see the bougie. Can you see the bougie now?
Yes,
That is very important.
Yes, sir, we
Seeing
can.
the bougie is very important. That means you have entered into the lumen of the stomach.
Right.
Withdraw. Because I don't want my anastomosis in the submucosal plane. I have seen somebody making an anastomosis in the submucosal plane and leading
Sir, in the
leading to a
thick
lot of
stomach, sir,
bleeding.
right, sir. In the thick stomach, sir, that is always a big possibility that you go on dissecting the submucosal plane,
Yeah.
and the submucosal plane is always like a mirage. It allows you to dissect until and unless you realize that, oh my God.
So that's it.
Absolutely, sir. Absolutely.
Now I come to the infracolic compartment. I shift my telescope into the right mid-clavicular port. Patient flat. Patient flat. Infracolic compartment. এদিকে দিয়ে একটা bowel holding there. And I have to look for the DJ. Huh? See, here the trick is I retract the omentum medially, not cranially. Cranial to some extent, but predominantly medially.
Right.
And if I go on retracting it cranially, then this will keep on coming back, and I'll be having problem. So that's the DJ you can see.
Right, sir.
That's the DJ.
Right, sir. Sir, but it needs an experience to find it so quickly. Definitely.
See,
sir.
initially we also had a lot of problem in this part.
Right, sir.
So I will now measure 180 centimeter. Huh? And bowel is contracted. So 10, 20, stomach tube tonic, 30, 40. You can see I have a mark on my grasper.
Right, sir.
That mark is 10 centimeter.
Right. That is
40.
something that I was going to ask you.
40.
Absolutely.
50. 60.
So that is something very good learning process to learn how to walk on the bowel.
60.
Particularly those who do diagnostic laparoscopy, this is a skill to learn.
70. 70. ঠিক 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 70 দাঁড়াও দাঁড়াও আমাকে ধরতে দাও না ছেড়ে দাও একবার ছাড়ো 70 80 90 100 100 110 20 30 40 180 কিন্তু আমি 60 তো করব because the bowel is contracted 50 bowel is contracted so effectively that will be 180 60 ধরো boss so I'll give 20 centimeter for the contracted bowel তুমি 10 centimeter ওদিকে ধরো আর এখানে ধরো my anastomosis will be here. And now what I'm telling you Ramanuj,
Yes, sir.
see the bowel was initially lying like this.
Right.
when the anastomosis is going to take place, I'm going to take the bowel up like this.
Right.
So this is the anterior wall of the bowel, this is the posterior wall of the bowel, and the anastomosis will be on the posterior wall of the bowel with the posterior wall of the stomach. Isn't
Absolutely.
it?
Absolutely, sir.
Now, if I make a enterotomy precisely on the anti-mesenteric border, there may be a twist because the anastomosis is on the posterior wall. So I take a 5 millimeter towards the posterior wall.
Absolutely, sir. That is a very important trick because in an open anastomosis also, this is a mistake that people do, and then after
So-
the layer is done, they understand there is a twist. Right.
So I make this enterotomy 5 millimeter on the posterior wall. There. This is a 45 millimeter blue load. একটু দূরে যাও, একটু দূরে, একটু দূরে, হ্যাঁ, yes. And it's very important to have the proper alignment. Otherwise, I head up. Proper alignment is very, very important. हाँ, आगे head उठा धरो, head up. इसको दिखा, शशि, ये end दिखा, धरो बस, धरो, हाँ, धरो. And I engage this, it should go smoothly. And now see, this is the neo greater curvature. Can you see?
Right, sir.
And
We can see
my
that.
stapler एक बार छाड़ो, एक बार छाड़ो, has to be a little away, about a centimeter away from this neo greater curvature.
Right.
So from this previous staple line, it has to be a centimeter or so. छाड़ो.
Sir, I think that this is a point that holding the stomach tube without a torsion is of the utmost importance.
This is the most important thing.
Yes, sir. Because once you have done that, and then there is no way to repent again.
Yeah. So see, correct?
Absolutely, sir.
And now I fire. So my anastomosis is now
Complete.
created.
Beautifully shown.
Now I pass the bougie.
Sir, can you
To
show
make
the
sure-
can you show the anastomosis or right? Can
I
you have an
pass the
approximate-
bougie to
right.
make sure that I have not made anastomosis in the submucosal plate.
Absolutely right, sir. There is no, sir. We can see the stomach mucosa very
Yes,
well,
you
but
can,
still,
but I have to
but
be
still, but
confident.
still,
I
sir.
have to be sure. No. Can you see the bougie now going
yes, sir. Yes, sir. We can see the bougie now
Yeah.
going.
out? Now
Right.
I close this enterotomy and the gastrotomy. See, there are two ways of closing it.
Right.
You can close it like this. You
Yes.
can close it like this.
Right.
But if you close it like this, it will be narrowed.
Mhm.
So if you have to close it like this, so
Exactly,
this
sir.
gets incorporated into the stapled anastomosis.
Right. And so definitely that will be the way you are closing, makes it much more wider, tension free. And all the angles that are made, they are
And-
taken care of.
I'm doing the taking the posterior
Right.
angle,
Sir, you are going to make a double layer closer, I think.
single
layer closer.
single layer extramucosal.
Right.
I'm a lazy man, my dear.
Sir, you are using a 2 vicryl, I think.
2 vicryl. You can use
PDS
PDS
also, right.
also. I find vicryl to be more user friendly than PDS.
Right. Sir, continuous or interrupted?
First, I will come from the posterior part, couple of stitches, few stitches. I'll come up to here, then put a knot there, and then come from the anterior angle. So it has to be from both the angles.
Sir, I think there is a loose staple pin that is lying by. Right.
is basically extramucosal or what you can call Lambert also.
Absolutely, sir.
Hey, doesn't matter. Doesn't matter. Ramanuj, a small trick I would like to give my juniors.
Yes, sir.
People find it very challenging to hold the needle.
Right.
Suppose you have to take a bite from right to left, like this. So you put the needle with the left side towards your left, this sharp end towards the left, so that you can take a bite like this. Now the needle holder has got a straight jaw, moving jaw, and a stationary jaw. Now what you have to do is you take the needle holder behind the needle, push the stationary jaw downward and hold the needle. It always comes in the smiley position.
Smiley position.
So this is a very easy way of taking the needle, easy and quick way of taking the needle in the right position. We can take the CBD in OT number 2, OT number 1. CBD. What is the CBD OT number 1? OT 1 है breast दिए छे.
कौन से OT में क्या चल रहा है?
Multiple calculi. Ramanuj, do you
Yes, sir.
agree that the end is secured?
Yes, absolutely, sir. The end is, that angle is secure, that end is secure.
Yeah, I'm talking about angle, sorry. Leak korbe na to?
No, sir. Pakka.
Chhod do boss. You can staple it here, but
Sir, the suturing is beautifully appreciated. Sir, please go on with the suturing.
suturing is a better option.
Right, sir. Sir, public demand is suturing.
My demand is also suturing. Because I don't staple here, because if I staple here,
Right.
the lumen will be compromised.
Absolutely.
So I don't do that. So after the next bite, Ramanuj, I will tie the knot.
Absolutely, sir.
And we'll start from the anterior
From the
angle.
Anterior angle.
I will tie the knot here. Some people use barbed suture for this.
Yes, exactly. Sir, I was going to ask you that one.
But the company itself doesn't advocate use of the barbed suture on the intestine.
Sir, that is exactly the point, because there has been many misconceptions about the barbed suture, the barbed sutures. It was initially made only for the peritoneum and solid organs like the uterus, etc. But should not be used on soft organs like bowel.
See, why it is called V-lock? The reason it is called V-lock is that this suture was first designed to close the vaginal vault.
Absolutely.
So that's why they call it V-lock. So Ramanuj, my posterior part is complete.
Right.
I will come now to the anterior part and will complete the anastomosis. Here again, I have to secure the anterior end.
So the angles are extremely important, I think.
Angles are very, very important. That is true. So I've secured the angle.
Right.
And now I CBD ले लेना.
Sir, I think the team is working with a 3D monitor and 3D vision.
Yeah.
Sir, you work with both 3D and in a conventional laparoscopy. Sir, how important is a 3D vision for advanced surgeries like this one?
Very good. Excellent. So our job is almost done.
Yes, sir. And a job well done.
Thank you, Ramanuj.
Wow. Sir, you currently have a view of around 2,600 and more counting.
My God. Thanks a lot. You did not tell me before, otherwise I would have got nervous. Now, just 1 second. 1 second. Pass the buji.
Yes, sir.
Buji.
Sir, in this time, by the time you pass the buji,
yeah,
sir, is there any role of doing an intraoperative methylene blue test?
We will do that.
Right.
We will do that.
Because that is, these angles are always something that always makes me very scared.
Can you see the bougie now
Yes,
crossing the
sir.
anastomosing?
Sir, yes, sir, we have seen that.
So we block the lumen now and we will push some methylene blue. Now, our team member is pushing some methylene blue.
Yes, I think.
Yeah. So there is no leak anterior wall.
Yes, sir.
And no leak
No
posteriorly.
leak posteriorly.
And here also we will check now, staple line, we will check. There is no leak. Okay.
Sir,
so
if there
we
is a
come
leak,
out.
then how do you tackle that? If there is a leak,
we have to suture it, we have to fix it then and there.
okay. Sir, is there any role of, but definitely we'll be suturing it rather than giving a clip or.
And we check for the hemostasis.
Right.
Absolutely clean. Devjit.
Absolutely clean, sir.
Absolutely clean. We take out the gauge.
Sir, and the beauty of this procedure may be that there is no retrocolic window or an internal herniation.
Nothing.
So that is the best part of this operation.
And you can see, Ramanuj, the lie is so beautiful.
Right.
The lie is so beautiful. Absolutely beautiful lie. We put a drain, old man.
Sir, that is the reason I was going to ask you. With this clean operation, no contamination, minimal bleed.
Ramanuj, I am an old man.
Okay, sir.
So
this is a Penrose, I think.
Younger generation people, they don't put drain, they don't believe in drain.
Sir, this is the 18 French Penrose.
But
sir, what is the drain in this one?
This is called flat drain.
Okay, so this is the Penrose 18
by
French,
Romson
right?
and Romson.
Right.
So we come out, our job is done.
Absolutely.
Thank you, everybody.
Sir, when are you going to remove the drain? Because
tomorrow, day after tomorrow.
Okay. And do you do any say gastrographing test on the day 1 or day 2? So do you do any gastrographing test?
Tomorrow we will do the gastrographing
test. Okay. Sir, we are switching on to the next OT. Professor Diptendra Sarkar will be starting on with a Mammopex pasty. Right. On OT3, please. I have with me Professor Samita Chatterjee, who will be moderating the OT3 now. Thank you.
Good morning, everybody. After that excellent demonstration from Dr. Tatia, we'll now shift to OT3, where we have a case of carcinoma breast, a 35-year-old lady who presented about 10 months back with a locally advanced breast carcinoma. She's received 4 cycles of neoadjuvant chemotherapy and has responded very well. She received doxorubicin and cyclophosphamide. Post NSCT, she has a lesion in the upper outer quadrant, which is about 22 into 25 millimeter, and by RAD 6. There's a small skin teethering at that end. Clinically, there are no axillary lymph nodes, but the USG shows some subcentimetric lymph nodes with intact hilum. Dr. Diktendra Sarkar and team will be doing this case. Dr. Sarkar, if you could just take us through your plan for this case.
Good morning, Shamita. I hope I am audible.
Yes, you are.
Yeah. Now, at the outset, I'd like to thank the Association of Surgeons of India West Bengal State Chapter for organizing this wonderful live conference in times of pandemic, and of course to the whole group of team in the ILS who have been kind enough to give the space to go ahead with this live workshop. Now, there are certain things which are a sort of paradigm shift that we are going to do today in the theater. Number one, as you rightly told, that this patient was a patient of locally advanced breast cancer. And generally the thought is that a locally advanced breast cancer should have a mastectomy. But there are adequate evidence now to suggest that in locally advanced breast cancer, after neoadjuvant systemic therapy, you can go ahead with a breast conservation surgery. Now, in this particular patient, if the camera focuses on this particular patient, is Shomita, is anybody focusing on the?
No, just a minute, Dipuda. Can we request the camera person to zoom in, please?
Okay, can you zoom in?
And we need the top light to be dimmed out a little. It's glowing.
Yeah.
Can you zoom in a little further, please?
Can you put the top light off? Yeah, that's fantastic.
That's better,
that's
much
fantastic.
better. Yes. Please.
Now look here. Now this lady has got a lesion which is situated in here. That is between 9 to 10 o'clock position.
Yes.
And this has got a bit of skin tethering here.
Right.
And this patient had undergone 4 cycles of neoadjuvant systemic therapy. There had not been a huge response. The other part is this has got a few satellite nodules around. So the response is a bit patchy. Having said that, it is restricted to one area, and that is not a contraindication for going for a breast conservation surgery. If the tethering was not there, like the one that you have here, I would have gone ahead with a technique which is called a round block. The round block technique based on the principle that this is we give 2 parallel circles being created, and then I have put in another extension on the lateral aspect. It looks like a tennis handle. So this is also known as lateral mammoplasty or tennis racket mammoplasty. What we are going to do is de-epithelialize the whole skin. So once the whole skin around the nipple is de-epithelialized, and what do we mean by de-epithelialization is that we are going to keep the dermal vessels intact which are supplying the nipple areola complex, while the skin is going to go off. And then we will take out the rest of the thing. I intend to complete the axillary dissection through this incision, so there won't be any separate axillary dissection, the incision that is normally given. The other thing that I'm going to show at the end is I am going to inject a dye approximately 4 centimeter beneath the axillary skin crease. And this is the technique which is known as reverse axillary mapping. All of you are well conversant with the technique of injecting a dye in the nipple areola complex, and we expect the dye to travel to the axillary nodes, and then you identify the node and take it out. But in this case, what we are doing is something called a reverse axillary mapping. In reverse axillary mapping, we inject a dye which is called the ICG. And the guys from Stryker is kind enough to provide me with the dye. What we do is we inject subdermally and intradermally. It is a sort of combination, and we are one of the pioneers of starting this with ICG in the whole world. And our trial study, the validation study, got published only a couple of months back. So what we do is we inject it subdermally, and it is being injected. So approximately 1 ml here, the dye is being injected.
So you inject the dye prior to commencing your main surgery?
I do that before, because we have been putting in a sort of, as I said, we have standardized things now after a lot of controversies when to inject the dye. And then we inject a bit intradermally. So once we do that,
so is there any prescribed time frame as to when you inject it? Have you validated that?
Approximately, it takes a half an hour time to reach the axillary lymphatics. I mean, what happens is that the principle is that the whole, once we inject the dye, it goes along the course of the axillary, the arm lymphatics, and it is going to illuminate the arm lymphatics. And when we do the surgery, we will keep the arm lymphatics intact and take out the axillary lymph nodes. That means the nodes which supplies the breast. So this is called an reverse axillary mapping, and the technique that we have evolved is axillary lymph node dissection, sparing the arm lymphatics under ICG guidance. And as I said, we are fortunate enough to get it published as a validation study in the European Journal of Surgery only a couple of months back.
Could you just elaborate on what exactly is the dye? Is it the same dye that we are using in other surgeries, or is it a specific dye for the reverse lymphatic mapping?
It's the same. I mean,
the same ICG that we are using.
I mean, the striker would advocate this particular dye, which is the indigo cyanine green, and you can use it not only in breast, but this is a versatile dye, and the technology can be used. And I will show here, after we reconstruct the breast or do a conservation and oncoplasty, we will be able to visualize whether the nipple vascularity is kept intact or not. And I'm sure when somebody does a difficult cholecystectomy, you can use that also to identify the common bile duct. While you're doing a parathyroid surgery, you can use that to identify the parathyroids. So it's quite a versatile thing, and most of the flap viabilities can also be assessed. Anastomotic viabilities can also be assessed. So I think in a couple of years' time, this technology is going to be a very handy one for all group of surgeons. So with this introduction, I will start the process, and I must introduce my colleague, Dr. Rudradip Banerjee, who is with me. He himself does this procedure, and today I am fortunate that he is helping me out. And I have a young surgeon, Dr. Milind, who is also a trainee from IPGMR and MR Bangur. He is from MR Bangur, and again, he has joined, agreed to help me out in this procedure. So I will begin with the incision in the breast.
Again, I just have a question, Dr. Sharkar.
Yeah.
That here we have a bit of skin tethering.
Yeah.
So that is why you wanted that racket handle extension of the round block.
Exactly.
If the skin was free, would you have gone with the traditional round block?
Yeah, I would have gone through the traditional round block. That means incise it and go for a tunnel to this and take the tumor out.
Right.
Because it's skin tethered, I need to excise this element of skin. So I have done a racket handle incision.
Correct.
And this is called lateral mammoplasty techniques, which was originally by the plastic surgeons, and breast surgeons have adapted it as well.
Another thing I wanted to know is that
Yeah.
you said because it's in the upper outer quadrant, you'll use the same incision for the axilla. Now,
Yeah, I'm going to
I
use
think
the
you
same.
have the luxury of that because it's in the upper outer quadrant.
Exactly.
Otherwise, you would have taken a separate incision for the axilla. Am I right?
Exactly.
Right.
Nowadays, I tend not to make a separate incision for the axilla. I'm quite comfortable operating in a single incision, even if it's in the upper inner quadrant. You can actually, but it requires a bit of struggle from yourself as well as from
very good assistance will be very
assistance
important.
and the good retractor.
Yes.
In this particular patient, I would have also chosen to go for a flap which is known as the LICAF flap or lateral intercostal artery perforator flap, but it would require a Doppler, and I did not want to embarrass the authorities of ILS by demanding multiple gadgets. We already have multiple gadgets working and functioning in this theater. So
more than embarrassing them for more supplies, I think what you're planning is quite okay. We really do not need to go for a LICAP in this case. I think the round block should be enough. I think as you proceed, we'll really understand.
Yeah.
But a round block planning seems to be perfect for this patient.
Exactly. Now, again, before we were trained in this mammoplasty, I keep on telling people that I have possibly removed epidermis in kilometers, in 5,000 kilometers before we actually learned this. So de-epithelialization is something which needs to be done, and it's quite tedious. And I'm not going to bore the audience by showing de-epithelialization extensively. And I'm sure Dr. Rudra is going to help me out with a bit of de-epithelialization. Now, this is how it is done. The whole principle of de-epithelialization is that we are going to take the skin out, keep the dermal vasculature completely intact. And this dermal vasculature, if it is intact, is not going to lead to decreased vascularity of the nipple areolar complex, which remains absolutely untouched. So we cannot go into depth. If we go into the depth, what happens is that the blood supply to the nipple gets disrupted, and after the surgery, it will be a disaster if the neck actually goes out. Now
I think the trick is identifying the right plane between the dermo-epidermal junction plane.
Yeah, when we started doing this, I was a bit skeptical whether I can do it, but now my trainees do it for me, and I can assure you that it's not a very complex thing, or there is no rocket science involved in the whole thing. You can get away with a simple deepithelialization in most of the times. Now, have Dr. Tatia started the theater in the opposite, in the other theater, or Tamanasta for that matter?
Not yet. We'll let you know if we switch over to any other theater. Meanwhile, we are all on observing your surgery.
Okay. Now, if is the ICG camera ready? Okay. Now, as Rudra prepares it, I will show you right at the beginning how it looks like after the dye is being injected.
So you injected 1 ml about half an hour prior to your visualization, right?
Yeah.
So this is a ready-to-use dye, so you do not need to dilute it at all.
No, not really. And people, and the advantage of using ICG is that it is not at all a costly thing. And the more interesting fact is that one of my friend in the All India Institute of Medical Science, Dr. Deo, called me up around 6 months back that he was unable to get the ICG dye. And he was informed the whole ICG in India is supplied from Calcutta. So a vial would cost around 1700 ml, and you can use it in multiple patients, maybe around 5 or 6 or even more, where you can use it. So it's not at all a costly thing. Now,
I think Manipal Hospital has also come up with some indigenous ICG dye.
Yeah, Dr. Somsekhar,
right, yes.
They have, it's not, the dye is the same, but what they have come out with a camera which is not so costly. Dr. Anurag Srivastav is using fluorescent green,
right? Yes,
in All India Institute of Medical Science, and he uses a cheaper version of camera, which he told me he got it from the Chandni market at Delhi. So it's interesting. I have been to his theater to observe the technique. The only advantage of using this particular technique which Stryker innovated is the fact that it is versatile. It's not only about visualization, and you will see here, is the camera ready? Once the camera is ready, the modes.
So you were commenting on the difference in visualization of the Stryker and the fluorescent camera.
The other things are quite good. I mean, the technique with fluorescent green that is used in AIMS is good. The only problem is it is static, it is not dynamic, and it does not have the other functions which I was telling at the beginning of the surgery. The Manipal version is also quite good. The only problem is it is not so versatile and it's not so handy. It cannot be used while you are doing a laparoscopic common bile duct exploration that Dr. Tantia is going to do in the other theater. So I think ICG has got a very busy day ahead. demonstrating things in GI as well as in breast surgery. Now, while deepithelializing for trainees, I must once again give a bit of tips that you have to be patient. In spite of me doing oncoplasty for quite a time now, I cannot hasten or accelerate the whole process, because if you do so, there is a chance that you go inside and you actually end up in you go into the subdermal plexus and injure it, as a result of which the vascularity of the nipple get completely disrupted. Yeah, so that is the reason Dr. Anuj Poddar, who is the honorary treasurer, have asked me a question. You know, treasurers always would like to think in terms of economy, and he asked me why not at a time and why piecemeal. So it's again because of the same reason, that if you try to be very over smart and try to take the whole thing out, you may end up going into the subdermal place, and as a result the vascularity may be hampered. So you see the small oozes that come out, but there is no spotting. That indicates that we have not gone into the depth.
Now,
Yes.
this patient is an NSCT, post-NSCT patient. So you planned an axillary dissection at the end.
Yeah.
Now, had it not been so, with a negative axilla, clinically and radiologically negative axilla, I suppose you would have planned an SLNB for her.
I think in this particular patient, if I had put in a clip in the axilla right at the beginning of neoadjuvant systemic therapy,
yes,
which we are going to do, which normally we do in patients of locally advanced breast cancer before we start chemotherapy, we can do a targeted axillary dissection. So we have not put in a clips. And I don't know the amount of fibrosis in the lymphatics that have taken place, and whether I would end up in doing a false negative sentinel lymph node identification. So I would prefer to make it simple, and therefore I have restricted. Sister, can I get one more blade? Now, the reason why this technique became popular was initially it was done for a central mammoplasty or a donut mammoplasty, which was done by the plastic surgeons. So even our a group of surgeons previous to us, they used to make incisions in the periareolar area, incisions, and take fibroadenomas out. And therefore, what we intend to do here is create a new neck line. So what is going to happen is that once the procedure is over, the neck is a reformation of neck will take place. So once there is a reformation of the neck, you won't be able to see even an incision around the mark or a scar around the neck.
Right.
Now, Dr. Rudro is trying to show you which one is the spy mode. Spy mode. Okay, now look at this. This is the ICG camera, and this is the spy mode. And you look carefully. I am.
Can we do a
Dr. Somita, are you able to see?
Right, we are able to see, yes.
Yeah, look at the injection site and how wonderfully it demonstrates the marking that is going into the axilla.
Right, we can see it.
Okay, with time, the whole axillary lymphatics are going to glow up. And if you look carefully, if I push it and I can tell you this is exactly where the axillary, and you can see even the flow. Look carefully, you can see even the flow. Yes, can you see?
Yes, we can see the
ascertain?
flow. Yes, absolutely.
So it's not that Dr. Om Tatia is the only person who uses technology, and breast surgeons only depends on skill. I can assure you with a good amount of certainty that this technology is going to be wonderful. It's a revolution in breast. And you see how wonderfully the whole thing glows up, how the lymphatics is proceeding. It's like a meandering river that you can
Right.
see the lymphatics is proceeding.
Can we bring it to the center of the screen, please? Yes, that's better.
That's where we have injected.
Yes.
And this is the lymphatics that is proceeding. We will come back to this area after we have deepithelialized.
Right.
Okay.
Yes, absolutely.
Thank you. And this is in the this is the other mode where you are able to see. Can you see it's how
Yes,
wonderfully you can demonstrate in different modes? But the spy mode is the best mode where we are able to see the lymphatics channels wonderfully.
Is there any staining of the skin? Like
no, nothing here, nothing
at all.
here. That's what you are seeing in the screen, but
Yeah.
nothing happens here. The beauty of this technique or this technology is that it doesn't stain the skin. There is no, I mean, dermal necrosis. There is no secretion in the urine, and it works wonderfully.
So these are the problems we usually face when we are using indocyanine for the sentinel lymph node. So that
Exactly.
thing is eliminated here totally.
Yeah, when we use methylene blue,
Yeah.
the patients might have a sort of dermal necrosis
Yes.
in many cases.
Right.
Okay, so I'll go back to the deepithelialization.
Yes.
In the meantime, you can go to the other theater, and can the lights be on?
The other OT is just getting ready, so we'll stay with you.
Okay. কি হয়নি? Now in the normal mode he is showing, this is how it looks like, no staining.
Right.
Then you shift it to the other mode.
So just to repeat, it's about 4 centimeter from the anti-axillary line, right?
Yeah,
Where
just
you
4
had injected.
centimeter. This is now you see
Yes.
where the dye have been injected.
Right.
And finally we use the spy mode.
Mhm.
Okay.
Yes.
Now the only contraindication is if the patient that was operated in the other theater with 131 kilos, if you have somebody whose BMI is more than 40 to 42, in that case the camera may not be able to pick it up. But that's a rarity, and we have not been able to miss a single patient in whom where we have injected the dye and we are able to.
Is it because of the extensive subcutaneous tissue?
Yeah, in morbid obesity, the camera may not be able to
Penetrate through the fat layer.
to the fat to that extent. So apart from this morbid obesity, it's a fantastic technique. And the other advantage of using this is, now when we normally use a sentinel lymph node biopsy, we are completely dependent on our nuclear physician friends.
Yes.
And there are issues with BARC in procuring
The license required is also tedious to obtain.
quite tedious. Now,
Yes.
once we have this is a single technique by which you can do SLNB, you can do ARM, you can observe the flap viability, everything. And at the same time, you can do a laparoscopic CBD, a difficult cholecystectomy.
Any known side effects of this dye that we are using?
No, nothing.
Nothing.
All medicines like paracetamols do have a
No,
few
those are the
examples of
acceptable
allergy.
No specific
We haven't, no,
side effects.
nothing of as of now. Now, again, for trainees, you need to understand that oncoplasty is a form of treatment or form of surgery which implies giving back the patient the same volume and shape after surgery in breast cancer without compromising the safety of cancer surgery. Now, type 1 oncoplasty is one in which you remove less than 20%, and in that technique we can mobilize the breastplate and bring it to the area and give back the patient same form and shape. Whereas in type 2 oncoplasty, if it is more than 20%, you need complex procedures like the one that we are doing here, which are like therapeutic mammoplasties, the wise pattern and other things, batwing mammoplasties. If it is more than 50%, in those cases, the patient will actually require a replacement. So volume displacement up to 50 and more than 50, you require replacement of the volume.
So if it is below 20 and between 20 to 50, in both cases, we call it the volume displacement, right?
Yeah, we call it volume displacement. If it crosses
above 50, it becomes a volume
replacement therapy. So that is
that could be an autologous tissue as well as a prosthetic tissue, depending on what you're planning.
Yes, and for volume replacement, actually, if you look at the profile in the West, countries which are extremely rich, like countries like the United States, who are planning to give third and fourth booster doses of vaccines, for them it's pretty simple. They would just take the breast out, put in a silicone prosthesis and wrap it up with something called an ADM, or acellular dermal matrix. An acellular dermal matrix will cost around $5,000, which is quite expensive. But the United Kingdom, which relies more on a government delivered system, ADM is not used so frequently as US. In India, ADM or acellular dermal matrix have not yet come. So
the point is that even if economy allows, is it really justified in using a ADM for every patient?
I mean, when you do a mastectomy, you have to combine with a latissimus dorsi, because if you put in a prosthesis, that prosthesis needs to be fixed and covered. And for that, you need latissimus dorsi myocutaneous flap. And here you have a solution where you just go inside and take, just put in a mesh which is free of the collagen, and you wrap it up and fix it there, and the procedure is over in 15 minutes. And if Milind, who is helping me out today, if he is given the option of taking the breast out and putting in a prosthesis and wrapping it up in 15 minutes, I am sure he will love to do that. But having
provided he gets the ADM.
Provided he gets the ADM.
Right.
Having said that, you need what everybody needs to understand, that implant breasts are very static breast. It does not have the natural
suppleness of the breast,
suppleness and fall, which is achievable in other forms if you combine it with ADM with latissimus dorsi.
I think you're coming to the end of your de-epithelialization.
And as usual, the scalpel is losing its sharpness.
Yes. You've already changed the blade once, I think.
Once, yes. I don't know whether the newer blades that are being available are not as durable as the one which Professor Dilip Chakraborty, I don't know whether sir have joined us today or not, whether the same blade and durability was there.
It's just good business sense. If you could use the same one through the surgery, they wouldn't say, you wouldn't buy a second one. So it's just good business sense to make sure that, you know,
I
you use
think-
it for a lesser time.
I
Get
think
blunted out.
we should be talking to some good scalpel companies in the next conference.
Provide the sponsor a conference.
Yeah, and you know, we are losing a lot of money if
Yeah.
we are demonstrating a particular scalpel and not getting a sponsor for that.
So I think it's done now, right?
It's almost done.
Yes.
Few patches left.
Can we just zoom in a little more, please? Because we're seeing a lot of hands in the way. Can we just zoom in a little more? This is much better.
Now, because Tatyada or Tamonasda have not started the procedure on the opposite in the other theater, I am left with no other option than to complete the whole deepithelialization process myself. Or else,
Rudra would have chipped in.
yeah, definitely. It's quite tedious.
But I think Rudra also does a brilliant job. So
Yeah,
probably the audience wouldn't have noticed the difference.
probably better than me because I do not deepithelialize.
Right.
Okay, so here we have almost completely deepithelialized thing. So again, the purpose of the whole thing is very clear, is that we have kept the vascularity of the nipple completely intact. Now, can I have a bit of dye to demonstrate this?
Yes. I think patience is the key virtue for deepithelialization.
Yeah, exactly.
So are you injecting some more dye or are you going to?
I would like to demonstrate the vascularity preservation after this.
Okay.
I want to be sure whether I have not.
I think you're extending your incision of the
Now,
racket handle now.
Yeah, I am going for the racket handle incision now.
I would request the camera person to focus from the other end because the surgeon's hands are coming in the way. Can you focus from the other end because the surgeon's hands are coming in the way?
That only. Oh, is the dye ready? Okay, thank you.
So how much dye are you going to push in now and exactly where?
Just 2 ml.
Yeah.
So is that ready? Now they have got a software by which they can exactly tell the amount of perfusion. Can I have the dye? Okay, you have injected it. Thank you. Now look at this. They are injecting it.
Now where do you inject the dye this time?
They have injected it
Already.
IV.
Okay, IV, right. Okay.
2 ml, isn't it? Yeah. So they have injected 2 ml of it.
Yes.
Yeah. Now you wait. Now you see the breast is glowing up.
Yes.
And can you see the wonderful dermal vasculature? Now look at this.
Could we zoom in,
This
please?
is,
Could we zoom in, please? And bring it to the center of the screen.
yeah. Can you go into the center?
Yes. Can you please bring it to the center of the
Now
screen?
can you see?
That is beautiful. Looks
Can
like
you
a
see
starlit
the-
night.
So can you
Yes.
see how wonderfully this is the normal view? And now you see
Right.
that I have not done the mistake of removing the subdermal vessels. It's all intact, and this nipple is going to survive normally without any devascularization. Can you see the whole
Yes,
breast
absolutely.
glowing
yes.
up with the
Right.
once you inject the dye?
So not only the NAC, in the whole rest of the
Whole
breast,
breast
also we can
vasculature you
appreciate the
can see.
vascularity.
So as I said, it's not the laparoscopic surgeons only. I see Tamanasta getting ready for using the ICD possibly in the other theater. But I must once again make this statement that technology does have a huge, huge impact while you are doing it in breast surgery. And this is how you are able to see the vascularity. You can check the whole procedure after you have done a flap reconstruction, that the on table that the flap is viable.
Right.
Okay.
Extremely impressive. Extremely impressive.
So, okay. Now I go back to the procedure. Can I have a cat's paw or something? Can the lights be focused? Is it in the spray mode?
Right. We need to zoom in, please. We're way away from the field. Yes.
Okay.
Further zoom
Sure.
in, please.
Now we have another project running now where we use energy sources, and using any of the energy sources helps hugely.
I think
also,
we need a better viewing, Dr. Shorkar. We are not able to see what you're doing. Can the camera person please zoom in closer? The surgeon's hands are in the way. Much. Yes, that's much better. Thank you.
hey,
In OT1, Dr. Tomna Chaudhary will be starting a lab CPD. So they're just making the ports. Dr. Shorkar will tell you when we'll switch over there transient.
এত নারী এটা ক্যামেরাটাকে ক্লিন করে নিস, গায়ের পুরো জোর চলে গেল আমার হাতে। বস স্কিনটা হেভি টাইট। হ্যাঁ হেভি।
While Dr. Shorkar does the wide local excision of the mass, we'll take you to OT 1, where Dr. Thomanas Chaudhary is starting the lab CBD. Can we have the sound in OT 1, please?
On kora ache mic. Good morning.
Good morning, sir. Shomita.
Yeah, good morning. Good morning.
Yeah.
We are just make the all 4 ports. Afterwards, if required, we will put one more for cholecystoscopy. But now at least the every CBD exploration, the first step, if it's a primary, basically first stage, one stage CBD exploration, so we have to do the lab cole. So that will continue.
Sir, could you tell us the radiological details of this patient? What are the USG findings?
It's a multiple calculi in gallbladder.
Yes.
And CBD.
And MRCP?
And CBD diameter is 14 millimeter diameter. So hold it.
Is it a single stone or multiple stones in the CBD?
Multiple stone. Multiple stone in CBD.
Multiple stones in CBD. Okay.
Multiple stone in CBD. So we'll try to see the anatomy. So there is some additions. We'll clear it, then we do. So let we do the cholecystectomy.
I think we'll.
And I think already we have done 2 cholecystectomy. So you can go on, Dr. Sarkar.
Yes, I
Okay.
think we'll be there once your.
Yeah, let me
We'll
finish
come
the.
back to you.
Okay,
Yeah.
okay,
Thank
okay.
you so much.
Okay.
Could we shift to OT3, please? Yes. Sound in OT3. Dr. Shorkar, we are back with you. So
Okay, thank
could
you.
you just tell us where you are?
Now, this is fibroadenosis. Don't think it to be cancer. And I am taking the tumor out. We are almost through. Now, I hope you are able to see the pec major muscle. I go up to the completely up to the pec major muscle.
Will it be possible to reduce the intensity of the top light because the image is glowing? Rudra, can you ask somebody to reduce the intensity of the top light? Slightly, because otherwise it's glowing. Yes, that's better, much better. A little more will be better. I think clinically also when we were seeing the patient, it is not a very well-defined mass now, post-NSCT.
Yes,
It's a very diffuse sort. So when you're handling it, are you getting a margin or is
Yes,
it again
I can feel a area of induration.
Okay.
And I am taking a margin wide enough.
About 1
I will
centimeter?
also see now. Again, I would like to, if there are trainees, now look at this. These are the small vessels that you see here. Shomita, are you able to see them?
Yes, can we just zoom in a little more? Yes, yes.
Yes, these are the chest wall perforators.
Right.
And if I had done a chest wall perforator surgery, I would have normally gone for a Doppler and localized this and mobilize the whole thing up into the breast. Now, every small vessel that we see and we cut while we do a breast surgery, now we feel that we are actually losing one potential vessel by which we could have preserved the, I could have done a better conservation.
Correct. Do you have any plans of doing a frozen section for the margins?
Yeah, normally, yes, maybe, but I am happy to send only the margins.
Any plans for cavity shaving or no?
I will take some cavities shavings from different areas and send it for biopsy separately.
Separately, okay. So you're taking a 1 centimeter gross around the indurated area that you feel.
Yes, and if you could actually see those parting, you will understand how robust these vessels are, and the fact that you can preserve these vessels in a wonderful way and use them for reconstruction. I mean, volume replacement locally.
The surgeon's head is in the way.
I mean, with the advent of LICAPs, the incidence of LD flap, the incidence of LD flap has declined hugely in my own practice. So I am entering into the axilla. You are able to see this is
Upper outer quadrant lesion, you're using the same incision to enter the
yes,
axilla.
I have gone into the
I think he's
axilla.
retracting the.
This is the
major-
pectoralis minor
Yes,
muscle.
Yes.
And so I have gone to the lateral edge of the pectoralis minor muscle, preserving those are the pectoral vessels. I am preserving them.
Can the assistant's head be shifted a little? Yes, that's better. Thank you.
Okay.
Yeah.
Now, can we have the ICG SPY mode once again?
The pre-op USG said it was, I think, 2.5 by 2.5 centimeter lesion. Intra-op, does it feel the same or?
It's
anything?
almost the same. Now
Almost the
you have to
same.
go somewhere here.
Okay.
এখানে. Okay. Now I will go into the axilla. Now you are going to see through the eyes of the camera now the procedure.
Yeah. Are you planning to take the axillary tissue en masse or will you remove the specimen and
En
then?
masse.
Okay.
Because it's almost in the axillary tail.
Right.
If it is feasible, I can take it en bloc. Actually, one of the reasons I do it en bloc is because I am able to keep the traction intact till the last moment.
Correct.
Critics. Lymphatics. Chapter. আমি একদম ইভেন্টটাকে বের করে নিই, তারপর একটু সরিয়ে রাখ।
Camera.
They will in a minute.
Yeah.
এবার ফোকাস কর। পুরোটা রিস্টার্ট করা।
Can you visualize the axillary vein now?
Yes.
Yes.
That is the axillary vein.
Yes.
Simon. Okay, now can you see the lymphatic streaks?
Yes, absolutely.
Now, when we do the dissection, we
will avoid them.
We will avoid them.
Yes.
And we can actually do a lymphovenous bypass. Now, I will show you the lymphatics is somewhere here. The lymphatics is somewhere here. I can even preserve this lymphatics. I can I can even preserve this lymphatics here.
Dr. Sharkar, it's a little blurred. Can we improve on the image, please?
Yes.
No, the spy camera vision.
Yes.
Yes, that's better.
That's
Yeah,
the,
that's
can you
better.
see it?
Yes, yes,
This is the lymphatic streak I'm talking about.
right.
Rudra, yes.
Yes.
So you can preserve this lymphatic streak which you have injected here. Can you start from here, Rudra? Now see, it has started from here. The lymphatics has
Yes.
gone inside. Now we are, huh? ঠিক আছে. Now we are entering into the axilla and the lymphatics is coming. Now, as because this is a single incision, you are not able to identify it. But if I have made an incision here, you have gone direct continuity would have been maintained.
Okay.
Okay, now you go inside, Rudra. So this is where the lymphatics are. Okay. Now, are you able to see those streaks?
Yes, we can.
Yes. So we will preserve these streaks of lymphatics and take the axillary lymph node out from this. Okay.
See,
Now
when we do talk about ALND, we say that we take out all the lymph nodes and the supplying lymphatics. Now, how do we distinguish which are the lymphatics that we're going to take out and which
Okay.
are the arm lymphatics which we are going to
I
leave
will
behind?
show you. I am getting a bigger retractor. Rudra, can you focus on this area? Huh? Can you see the lymphatics here?
Yes, we can. Yes.
This is the lymphatics which I would always preserve. You carefully flow it, you will be able to see the flow as well. Can you see the flow? Just
yes, yes.
yes.
Right.
So what happens? You can see the flow. It's not really the lymphatic flow. You can see the lymphatics and the underlying vascular pulsation is making the flow more prominent. So we would keep these lymphatics intact. These lymphatics completely intact. And if we do, now we will keep these lymphatics completely intact. Now, if we feel that we have done an axillary lymph node dissection, we will take these lymphatics down and take it out and anastomose with the vein to go for a lymphovenous bypass, which we also call lympha. Now, if everybody is able to see the wonderful flow that you see in the lymphatics, this is a fantastic technology. I mean, I love this technology. Just look at it, how beautifully you can demonstrate the lymphatic flow.
You are going to take care to preserve this and take out the lymph nodes from the surrounding area.
Keeping this lymphatics intact.
Right.
Okay.
Yes.
Okay, now you can go to the other place, and after we have taken the lymphatics out, I will demonstrate you how the whole thing, the whole streak is very prominent now.
Can the camera person please adjust the view once again? The surgeon's head is in the way. Yeah, he can't move his head. You have to move your camera.
Okay. Now I will demonstrate you another very important thing. Again, that is a paradigm shift that I'm going to show you. Our axillary resection is almost through. Now, as it is through, now you see this is the axillary vein. This is the axillary vein. The lymphatics is just above it. Can you show the axillary vein once?
Can you please zoom in?
This is the axillary vein. You can see. You are unable to see the lymphatics now. You can see the axillary vein.
Yes.
This is the intercostobrachial nerve. This is the axillary vein.
Right.
Now go to the SPY mode. Now you see just above the vein the lymphatics is growing. So this is the lymphatics. Now you see the flow.
You can see the flow. Yes.
Okay.
Yes. Absolutely. Yes.
So this is the advantage. And now you see
Now
the
we can
lymphatic
see the
chain.
lymphatics. Yes.
This lymphatic channel can be preserved wonderfully, and this lymphatic channel can be taken out to anastomose with the vein. I will show you in which vein we anastomose it. Just let me show you. Now you see, once again, can you get back to here?
Can we have that vision once again, the SPY mode vision?
Okay.
Yes. Yes, we can see it now. Right.
Okay.
Yes, absolutely.
Now you need to look at this vein that we in the normal mode. Now you see this vein that is going out. Most of you have seen this vein, which is a descending branch, which goes down. Now the advantage of this is the intercostobrachial nerve that you see here.
Okay.
Now the advantage of looking at this vessel is I am going to show you what is the advantage. Now this vessel we usually cut clearly without looking at what this is.
Usually there are a couple of them at that position.
Yes. Now look at this vein.
Right.
Now this originates from the axillary vein.
Yes.
And goes down like this. Now if I am going to cut this. Are you able to see the whole vein?
Yes, we can.
This is a long length of the vein that we see.
Right.
Now I am going to cut this. Can I have the scissors? Yes. Now I am cutting this. Okay.
Yes.
There is a small amount of bleed, not much.
Right.
The vein gradually will go down. Now you see there is no further bleed.
Right.
Now what happens is that now this is a vein. Can I have forceps, please? Forceps. Now you see. Now this is the vein. This is a direct branch of the axillary vein.
Correct.
This is the direct branch of the axillary vein. Now, if we cut this vein, there is usually a valve at the junction with the axillary vein, as a result of which there is not much regurgitation.
Right.
Therefore, a lymphatics can be inserted inside the vein to produce a lymphovenous bypass, which is also known as the lympha.
Okay, so there is a flow from the from the lymphatic channel into the vein and not in the reverse direction.
Exactly, and that makes lymphovenous bypass or the procedure is called lympha. Okay. So wonderful and robust, and we again are into a study at this present moment to see the reduction in incidence of DASH, that is disability of arm, shoulder, and hand. Okay.
Okay. Yeah.
Thank you very much.
What suture will be using, and will you be using a loop to do the
Yes, if I do a lymphovenous bypass, I will use ninoprolene,
right.
And I would use a loop because from the person from whom I learned it, who gave a talk in the OncoSurge last year, and he does it with a loop. There are a group of plastic surgeons who choose to use a microscope, because originally it was started by the Japanese. And see, there is a node which seems to be a metastatic one, which I can feel here.
So the USG had said that all nodes present have maintained Hyler architecture.
Yes, that is the reason now people tell that if you find a palpable node apart from the sentinel node, that you have to take it out.
Right.
Relaxing. To the right way, na?
So your specimen is out.
My specimen is out. Now,
I think Rudra will be marking the specimen right away.
yes. Now
Yes.
the other thing I want to show all the trainees is that number one, you see this is the descending vein we are talking about.
Can we
There are,
have the image, please? Can we have the image?
this is the intercostobrachial nerve that we have preserved. Now, what we can we have the
Can we have
marker
the
here?
image, please?
Yeah, I will show you the image.
Yes,
Now-
we are back with you. Yeah.
Now it is extremely important after you have taken out the whole thing to mark the cavity, because the radiation oncologist is going to look at this particular marking that you have placed and give the boost locally. So if you have not marked it, then it is impossible for the radiation oncologist to understand where the marker is. Okay, so can I have a vicryl, please? Sure.
Just a small query. When
Yeah.
we mark it, after that, there is going to be some displacement
Huh?
to close the cavity. Some displacement of the breast tissue. To
Yeah,
close the cavity.
but the markers do not change. There is a group of people who would like to mark is the camera there?
Yes.
There who are going to mark the muscle here. The problem is the muscle is static, but the breast can move in any direction.
Yes,
And if we
absolutely.
are mobilizing the breastplate to bring it centrally, what happens is that the cavity shifts, but the
Right.
muscle remains static. So the standard practice is always to mark the cavity. And
So I
not
think the floor of the cavity marking, that is of paramount importance rather
Yeah.
than the pillars above.
Yeah, this you must mark the cavity walls very clearly, because even if the whole thing shifts in an oncoplasty, then the marking remains there and the boost is given there.
Right.
Okay, so can I have a yes, vicryl, please, and a drain. We are almost through.
Okay. Yeah. I think Dr. Tomanush has finished the cholecystectomy bit and he is going to enter the CPG. So Dr. Shawkar will come back to you
Yes, sure.
for a while. You will be there, you will be visible, but we'll mute you out
Sure.
now. Thank you. Can we move to OT1, please?
Now, hello.
Yes,
Yeah.
sir, we are with you,
Sir.
sir. Yeah.
So now we are starting like a same fresh. So this is gallbladder. We are giving a fundal traction. Some additional lysis we have done.
I thought you were
Then-
done with the.
Yeah, everything is done
Okay.
basically. We have not completed cholecystectomy, but we have dissected, already clipped cystic duct. Artery is already clipped and divided. So this is the window. So now we have already cauterized the.
I can see that you've used a hemolog clip. Is that a
Yeah,
routine
because
usage here?
it's a dilated
Okay,
and it's a bigger in diameter. So we are not taking any chance
okay.
that any after even exploration some stones may come into, or we may not have a proper clipping of cystic duct. So already we have done this cauterization of duodenum. It looks CBD. So as we are using the ICG, please give a ICG mode.
So we are in a real ICG mode now in both OTs.
You go-
ICG is being used.
ICG mode. Overlay.
If I switch one,
You go and do it there.
Yes, we can see
Ah.
it. Yeah.
Yeah. So remove it. हटा इसका हटा हाँ
Yes,
so
we can see
so
it.
this is liver, so everything wherever there is bile, this ICG we can see. So now we are sure
Yes.
that earlier we have to put a needle and check the bile is coming, then only we can go for
I think it shows beyond doubt the position of the
yes,
CBG.
exactly, it's right in front of us. So now we'll put a stay suture with a 3-0 silk. Back to normal board, left hand change.
So two stay sutures
Maryland.
at the usual 3 and 9
Maryland.
o'clock position.
It's a normal. Okay. So we'll put a 2 stay switches. Then we'll yes. Yeah. So normally we put in 2 sides of
At 3 and 9 o'clock.
3 or half.
Yes.
Same way, 3 or 9 o'clock. So giving at
You are
3.
using silk and not picral here?
No, we are using for stay suture, we are using silk.
Okay.
Because normally in a stay suture we don't put knot, we put slightly lighter, but because it's already a vessel is punctured, so we put a knot over it.
Okay.
So that we can stop this small bleeding. Yes. No, huh? No. Light.
Scissor.
So এটা বড় রাখছি, এটা বড় রাখছি। হ্যাঁ, ধর। Yes. One more stay we'll give at 9 o'clock.
We'll have OT3 as a PIP while we observe Chahunas, sir.
Yeah.
I think they're closing the breast case.
No, you can pass on. We just when
No,
we just
No, Dr.
when we
Shankar
go
is-
for the key steps, then we'll let you know that we are doing these key steps. Then you can back to us.
Don't
No
worry,
issue.
sir, we are with you. Dr.
Sure,
Shankar
sure.
is through, so we are just keeping it in PIP so that we can watch them do the closure of the round block.
So we have put to stay. See, we have started with the 4-port.
Dr. Tamanas,
Yeah.
Dr. Podaria, can you feel the stone with your instrument?
Honestly, we have not done it because we
It is
know
multiple stone.
we will open it. No way we have to explore the CBD.
I think in CBD, avoiding knot is better. Better to avoid the knots. Because it will injure CBD mucosa.
I think he said just now that they normally don't put a knot. It is just a bite to lift the CBD wall up. Because there
So
was
if
a bit of
required,
oozing
we'll
here.
make it tight.
Yeah, because there was a bit of oozing here, we tightened the knot.
No, at least one loose knot will help us to manipulate. Otherwise, two loose ends can come out anytime. So we are putting one more trocar, 5 mm trocar at almost midline for CBD exploration. So that we are putting one more trocar.
Outside view?
Yeah, the camera outside. So basically this epigastric, we are putting this one more. This is the right hand working. This is the camera port. This is the left hand retraction for assistant retraction. Hook, please. Hook. Monopolar. Footplate. Monopolar footplate.
Dr. Tamanas,
Yes, sir.
while doing CBD, can we put the epigastric port initially to the little left?
Huh?
if you put the epigastric port to the left, then is it convenient to suture?
Yes, yes, yes. Basically, this is, we should put it slightly left so that, because, Dr. Khanna is holding another lead, this stay. So we are holding two stay foot plate, monopolar foot switch, blue, yellow. This yellow? I can't see. Yellow?
If the CVD is grossly
Yeah.
dilated, you can just
No,
inside
no.
without lifting out.
So, no, this is obvious that this is CBD, and now looks like ICG is coming out.
We'll be using a chondroscope.
So a lot of already, the stones and debris, all are grables, all are coming out. Hold it.
10 mm suction.
10 mm suction.
You use a chondroscope or uteroscope for inside visualization?
No, normally we put yes. It's okay. It's all open. কিছু যায় না, উপর দিচ্ছি। So now we'll irrigate.
Towards the lower side, how far take the collocotomy?
Basically, this is almost duodenum in front of us. This is the second part.
At
So
the junction, there is a vessel. You
yes,
avoid the junction. So
Yeah.
just cross the junction.
Yes.
Dr. Tamanos,
Yeah, please.
can you avoid the monopolar here? Monopolar.
Basically,
Instead, you can
no, no.
directly sharp cut.
Rather, we want monopolar because we don't want to. The margin should be more of coagulated.
Oh.
So we just want to cut, but a clean margin. Why not use a cold knife? Because we don't want a bleeding margin. As well, we want there will be no loss of vascularity at the margin. That's why we are using the cutting mode. Otherwise, we can use a harmonic. We can so that's why we are not using that.
You are using that yellow one.
So these are all small stones.
You are pressing the yellow.
Leave it. So lot of already we put so much of water. Most of these stones will be come out with stone.
10 mm section.
Background होगा क्या? अच्छा, we'll take out these stones. Otherwise, we may miss these stones. And we have a very simple technique to remove the stone. We just take a 10 mm suction without the suction apparatus. We are just putting there CO2. By CO2 pressure, the stone will be come out in the OT floor. No more. So we'll irrigate 2-3 times. Then when we are almost sure that it's clear, what? George, jet.
Yeah, you are using a suction irrigation device or just?
No. We have a very valuable suction irrigation device that is human. Our OT technician. No machine. Don't think about it.
What is the plan? You will do a T-tube closer or will be closer
Because it's a multiple stones, so our plan is to do T-tube. There's a choledochoduodenostomy.
Okay.
That is initial plan, and CBD also dilated. So that we are planning. But this is so good, we can go for a T-tube also. Joel. And basically, we can go for a. Ungshuman is giving an option. Why not to put a stent and closer, primary closer.
Yeah.
That option, but primary closer.
Particularly if you have a already sphincterotomy done earlier, in that case, safe to do a closer even with a
Yes.
stent.
But now, basic issue is we have to be sure that we have cleared the CBD.
Yeah.
At any point, if you have any doubt regarding clearance,
No distal
then the two options left. Either we should have stent with closer should not be there. Either choledochoduodenostomy or we can put a T-tube and. So,
But if you have done a complete clearance and there is no obstruction distally, primary closure is now becoming very popular.
I hope let Dr. Khanna will check the clearance.
Will be using a cholecystoscope.
Yeah. No. What we check by two methods. Upper part we check by putting a 5 mm telescope. We'll go by ureteroscope. Ureteroscope. এই একটা জল দে এখানে আমি জলটা দিয়ে দিলাম সাকশনটা দিয়ে দিলাম ইরিগেশনটা দিয়ে দিলাম এখানে হ্যাঁ ফুটপেটের সরিয়ে দিত আরেকটা ইরিগেশন দিয়ে দিলাম so from umbilical port we'll put the ureteroscope to check the upper part. Again, this will be in almost in same axis. It will go straight.
Which port will use for putting the ureteroscope?
Initially, we go through the umbilical port. এটি ক্যামেরা এটাতে চেঞ্জ করলে না আমরা এখানে ক্যামেরাটা দিয়ে দেখাতাম ভেতর
You take the umbilical port.
আর ক্যামেরা নেই
And your camera goes to
এই তো আছে হ্যাঁ
বাইরে ভিজন দেখালে তো
আচ্ছা না ল্যাপারোস্কোপিক ভিউ থাকবে ওই ক্যামেরা রিডিউসার
लाइट स्टैंड बाय किया क्या
ओके
कैप तो है
we are going through the umbilical port in its axis. So, that's it. আর একটা জলের বোতল দিলি না আমাদের ইরিগেশন
नंबर করেছিস দাঁড়া 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 এক মিনিট দাঁড়া দাঁড়া
this ureteroscope as a irrigation channel also.
জল দে
Yeah.
yes there Karina
You can see the conference. Yes.
yeah conference then we are going to the right duct almost clear then we are going to the left duct yes
Yes, clear.
hope so the upper part is completely yeah Clear? Is it clear? Professor Shah?
Yes, yes, yes.
Yes.
Very good view.
Now,
Colonoscopy.
now we are coming, the same thing we are coming from the epigastric port.
Yes.
We have put one midline port, through that port we will put it. Huh? Stent there close. So now we are slightly changing plan, that we will go for a stenting primary closure. Yeah, let us check the lower end. Now we are changing another telescope. This maybe looks like luxury, that we are putting nephroscope. So ureteroscope, nephroscope. Camera clean kar. Acha, focus. Change kar, theek ho jayega. But I think one ureteroscope is enough. But if
Thomas sir, there are 2,764 participants. They've logged in to watch your surgery. We are receiving a lot of excellent, encouraging comments from a lot of them regarding the neat surgery that you're doing.
Okay. No, but I feel this is the first time in West Bengal State Chapter ASI conference. This is something really, really a big achievement, and truly, this is one of the, I feel, biggest participation of ever Sasicon.
As others might be knowing that this is being televised at 25 medical colleges.
Can you read out the names of the medical colleges? We have a list.
Yes, sir.
You ask Prashant, so that because I received 2-3 phone calls when I was in break from North Bengal Medical College. Professor Amor was calling. We received a phone call from IPGMER. So
Dr. Kamanath.
Yes, sir.
I just thank all the professor and HOD of different medical colleges. We start with Bhagalpur Medical College, Vardhaman Medical College, Kishanganj Medical College, and Nalanda Medical from Bihar. This being relayed in Delhi at RML Hospital, Safdarjung Hospital, New Saigal Hospital, Max Vaisali, and Hindurab Hospital. Apart from this, in Jharkhand, we have 2 hospitals, Shahid Nirmal Mahato Medical College and RIMS at Ranchi. We have 2 in Karnataka at MS Ramaya Hospital and BLD Hospital. In Maharashtra, we have KEM Hospital having our live projection. It's in Madhya Pradesh, Index Medical College and Hospital and MY Medical College Hospital. In Rajasthan, we have Mahatma Gandhi Hospital and Gitanjali Medical College. In UP, we have number of areas where SRMC Bareilly, Santosh Hospital, Kanpur Medical College, KGMC Lucknow. In Muzaffarnagar, we have Muzaffarnagar Medical College. Is being relayed in BHU, Varanasi, and in Calcutta, we are having Traditional 3 medical colleges, RKM, SSKM Hospital, and also in North Bengal Medical College. I thank all the HODs for taking this responsibility of having the live transmission, and I hope you are enjoying the surgery. We must thank the Alkem Guardian Division, who has taken the trouble of taking this projection to different centers. And we have very good audiovisual people who are doing a marvelous job of transmission. We have a very nice audio transmission also. So we'll be happy. You can have some chat and we can interact with you all. We have good comment from the audience because it's a very nice demonstration.
Can you see the internal view? Other monitor. We have a. We are inspecting the lower end. Oh,
फोटो
absolutely.
दिखाना बोलो ना
Hey, camera,
Sir, can we
ये
see
camera
the
खुल के
lower
ये
and inside
monitor को
view?
देखो. Yeah, basically they are putting
रुक जा पानी
external camera
अरे इसको दिखाओ इसको
खुला के ये देखो,
कैमरा मॉनिटर
ये monitor को देखो. खोल ক্যামেরাটা স্ট্যান্ড থেকে তুলে দেখা, ঘুরিয়ে দে দিকে ক্যামেরার দিকে ঘুরিয়ে দে।
हमको नहीं देखना पाएगा पूरा दिन
হ্যাঁ वो दो कैसे तू कैसे देखा है?
नहीं दिखाएगा उससे नहीं होगा अंदर का भी देखना
এই বাইরের ক্যামেরাটা বন্ধ কর।
Sir, we can see the inside view in the.
ইয়ে
front.
বাইরের ক্যামেরাটা বন্ধ কর।
And as a
এই
PIC,
telescope
we can
camera,
see
telescopic
the
camera.
Political view.
Change to telescopic camera, then you can see. Yes. Yes.
Yes, it is visible, but we just need you to zoom in on that.
Ha.
Can
Can you see the monitor?
Yes, we can. Can you zoom in a little more, please?
जो
The camera person, can you zoom in a little more?
दिखाচ্ছে
ओके जाओ ভেতরে যাও।
अंदर जाओ पानी पानी पानी
इसको रहने दीजिए, PIC में उसको डाल दीजिए।
चल
बस पानी पानी पानी
Right, we have the endoscopic as well as the laparoscopic view now.
Yes.
Yeah.
ठीक है तो
हाँ
एवर
Sure.
जस्ट थोड़ा
Sure.
बेटा छोड़ दो
so now we'll put the state.
Yes.
हां मीटर दिख गया
Please speak there. बाबू एटाকে ফোকাস কর ওটা या
पानी देना
জল
এই जो
yes okay
बेटा धरो ना यार ये नहीं करंट प्रेस 10 सेंटीमीटर दूसरा वाला तो स्ट्रेट वाला ये डबल से कौन मांगा
कैमरा वो कैमरा फोकस
हम तो पानी डे मार गया
What size tent are you going to insert?
so now we are putting that guide wire, then normally 7 to 8 French.
7 to 8.
This is a can you see the guide wire? Yeah, guide wire. It's a blue and white.
Yes, we can. Yes.
Yeah.
लाइट स्टैंड बाय करो भाई वही लाइट स्टैंड बाय करो बहुत थोड़ी गाइड कर पकड़ो
देखो
वही ग्रास पर थी वही ग्रास पर
huh? Yes.
हम पे ना
Guide wire? Yes. You see, even our guide wire is blue and white.
पानी पर
It's a theme guide wire.
7 guide by. Okay.
No, it's you can see the color.
Yes.
You can't see the color?
Yes, we can.
Yeah, that is our theme color. Blue and white. No. But best part is in this Sasicon, I hope this is first time we are going for a hybrid meet and at least it's a 100 of us will be joined together, dividing in 2 halls. That is, and this is our President Professor Saha's effort to get this. It's really a big achievement.
A joint effort of the whole EC.
No,
And
the
we will
EC
to-
was just behind you to say and to to get the paper. But it's really Professor Saha, you have done it good. So now this whole concept of live surgery, and I hope so we are doing it in a very short notice. Otherwise, truly we can put some more different. So
We are putting the stent over the guide wire now.
yeah, we are putting the stent over the guide wire.
अब घुरा दो ए ऊपर उठा ले बा स्टेट अप पुश करो ना
Ah. Suction.
सुचा सुचा उसको कुछ टानो ना
ढुके গেছে
ना 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 ढुके जाए
distraction দাঁড়াও দাঁড়াও
ये छलना
So you've engaged the upper end of the stent in the
Yes.
proximal part.
we put it in place.
Yes.
Yes, suction. So now we'll
Stent gives you additional security, but otherwise, if the duct is dilated and clearance is complete, you can do a primary closure even without a stent.
No, basically, as we are very sure that CBD clearance, there is no doubt.
Yeah.
If we have any doubt about CBD clearance, if we cannot see the carina, right duct, left duct, if there is some difficulty, any doubt, we must have either bypass or T-tube, because we must have opened another channel. Because we are very sure, that's why we are putting this, and these will reduce much morbidity for the patient. Suppose if we put a T-tube, all of us know how long the T-tube is, how much, so how much morbid conditions for T-tube itself. So
What future it close for collocotomy closure? PDS?
we will close with Vicryl.
30 or 20?
Vicryl 30.
Okay.
Correct. Acha. Some more, we'll just put it.
Dr. Tamanas,
Yes, sir.
this is, I know that ILS is pioneering a primary lab chole and CBD by laparoscopy. So that's why you are not doing ERCP?
No. Basically, as usual, our first options for CBD stone management is ERCP. But as these patients have a multiple stone and dilated CBD, so we plan that we will go straight primary ERCP. That's why primary CBD exploration.
But as I gather from ILS publication, you claim that a lab chole, lab CBD is comparable to ERCP and second stage lab chole.
30. No.
Or you
No, we are planning for one. We have a publication.
Yeah.
And that between these two, for cost, you are asking, no, sir?
Yes, for cost.
This is almost 20%. 20% of the whole hospital cost is cheaper if we do CBD exploration in one setting. ERCP followed by lab chole is almost 20 to 25% higher cost. Total.
That I gather from your publication. That you want to say, comment that a lab CBD
Now-
exploration and gallbladder is a
Now-
better or identical option with the ERCP.
No. Now we have one project we are taking because our FNB candidate he is taking a project that we will do ERCP followed by lab chole, and another group will do ERCP and lab chole in a same sitting in same theater in one anesthesia. That we'll do. With that, hope so by coming 2 months we will start that project. We are waiting for
I think
our
this was exactly what I wanted to ask you.
yeah,
that
critical
ERCP
clearance.
and lab chole in the same sitting, same OT, same anesthesia. This is now gaining popularity all over the place.
Yes. So that basically we
So
do
the
it.
anxieties that we have that following ERCP and doing a lab chole after 48 to 72 hours, that there might be some pancreatitis in the meanwhile. That is also eliminated if you are
True.
doing the ERCP and the lab chole at the same sitting in the same OT.
True. That is true. That so to minimize that, we are taking a project. We'll do as our study, part of a study. We'll do it. What are the, and we are deciding the parameters. So I hope some more institute should
Sir, I think case selection for each arm has to be very
No,
judicious.
we have planned for a, we'll take a good inclusion criteria and exclusion criteria, but we'll randomize it.
Right, because unless you do that, if there is a selection bias, the study will not be very effective.
No, we'll do randomization. We'll do randomized study, but our inclusion and exclusion criteria will be very strict. That we are discussing.
Right.
So I will be happy if you share some of you, Professor Saha, all if you share some of your ideas for inclusion criteria. I will share, and I hope we can do it in a multi-center study, even in your center also. You can do it so that this can put a good effort from all of us. So that's why we are planning.
Sir, we'll just go over to OT3 for
Sure.
2 minutes.
Sure. We'll just close it
Yeah,
now.
They're closing now, so I just wanted to share the excellent cosmoses that they brought about.
Sure.
Can we shift to OT3
Sure.
for a second?
Huh?
Rudra, can you just show the close-up view of the, right, so they're nearly finishing it. Can the assistant please just move the hand? Do they have audio there? If you can see, they've completed the round block closure, and the scar is going to be just purely a periareolar scar. I think Dr. Shorkar is here. Would you like to comment on the closure steps, please?
As you see here that because time is pressing, he has used possibly staplers, but we would normally use 4-row-proline. That is far more cosmetically better. Now what he is doing here is closing the nipple areolar complex. What happens after some time, the purpose why it is done is it augments the whole breast up. So when the patient stands up, it gives a normal looking breast compared to the opposite side. So he is closing the neck now, and there will be a linear incision on the lateral aspects, and that's the beauty of the lateral therapeutic mammoplasty technique.
Do you always use interrupted for repairing the NSC, or can we have a neat subcuticular as well?
You can go for a subcuticular, but yes, time is pressing. So I would rather go for this, because subcuticular, taking this to other side, of course, the standard of care in the Western part is a subcuticular stitch.
Now, this case was a very small lesion, not a very large one. So I don't think you have to do any corrective mammoplasty on the opposite side. But if it was required, would you again do a round block and correction on the opposite side?
In the opposite side, if we find that there is asymmetry in the neck, we will do a crescentic mammoplasty and shift the nipple to the appropriate position. There is a designated place we would calculate from the mid-sternal area and then go and plan things where exactly the neck has to be placed. Yes, corrective reduction or symmetrization on the opposite side is required a small percentage of patients, not in everyone, but if it's required, we would always love to do that. With the modern neoadjuvant systemic therapies, we can bring the tumor down to so small a size that often the opposite side correction is not required.
Now, when the patient, if you're deciding on a symmetrization on table with the patient lying supine, how do you decide the level of symmetrization?
I mean, all symmetrizations are planned right at the beginning when the patient is in the ward standing position, and we mark the place and how much volume we are going to lose after the surgery is pre-planned. There is a project that we are running. It's called the breast navigational plan, where we would be able to understand how much amount of what's the breast volume in A, B, C, D, or triple D, whatever the cup size is, and the amount of breast tissue which somebody is going to lose. So then we would be able to understand how much will be the loss, and then plan things pre-operatively, not on the operating room, because in the operating room, the patient is lying supine. It is impossible to plan things on the table, but it has to be done before the patient goes to the room.
So the important thing is planning it, knowing the volume of the disease, volume of excision anticipated, reconstruction planned. symmetrization, and obviously everything has to be discussed with the patient upfront before she consents for her surgery.
Yeah, one of the major issues, as we are having some time, we can discuss is quite often we tend to, when I was also there noticing those first few cases of oncoplasty being done, I always raise the question within myself, is it worth going for these complex procedures and how does it help the patient? And we were in a wrong notion of thinking that Indian females do not want their breast back after their surgery. That's a wrong concept. We tend to suppress the emotion of the patient, and I would always advocate, unless the patient is vehemently against it, I will always advocate breast conservation. Like this patient, after 4 cycles of neoadjuvant systemic therapy, it can be done wonderfully. Going into the safety issues, it has been conclusively proved by 3 major publications which came out, one of them being in the Annals of Surgical Oncology, which came out last year, which conclusively states that neoadjuvant systemic therapy followed by breast conservation surgery is good enough, and possibly it is better than modified radical mastectomy. So it's completely safe that way.
I think there are 2 important factors as to why we do not do so much of breast oncoplasty in our part of the world. One is that the surgeons themselves, a large population, are not trained in it. And secondly, from the patient's perspective, there is a fear that if you leave part of the breast behind, you're not doing a total clearance. So the second one has to be dealt with by the surgeon himself, convincing that breast conservation is at par with mastectomy as far as surgical clearance is concerned, and definitely way above in giving her a better quality of life.
Making comments and questioning from
Tell me the questions.
There are a lot of questions for the breast case. I think since Dr. Shorkar is here, we'll take the questions that we have here.
Can somebody take the question?
Why don't you step forward?
তাতিয়া দিকে ডেকে দিলে হয়, তাতিয়া দা একটু কোশ্চেন গুলো বলে দিল।
এখন কিছু নেই। I think we are getting an excellent closure in OT3. Thanks to Dr. Shorkar, Rudra and Milind for assisting him ably. We'll go back to OT1 for the time being, where I think the choledochotomy. I think, sir, you're using 30 Vicryl.
Yeah, 30 Vicryl. 30 Vicryl. What's this?
Sir, वो stay.
Huh?
Stay, sir. Stay.
Stay इधर घुस गया?
हाँ, sir.
ऐसे?
ये ना stay.
Yes. Good. So can you see already we have put 2 stitches?
Yeah.
So one more at the lowermost end, we are putting one more.
So about 3 to 4 stitches at
Enough.
a gap of 2 to 3 millimeter.
Yeah.
Interrupted, right? Yes.
Because of magnification, it looks like it's too big and there is far distance, but truly it is very close. These sutures, sir.
Will you be routinely putting in a drain or?
No, we'll in this case we'll put a drain. In normal lap chole we never put a
not
drain.
for lap chole, for CBD.
Yeah, CBD we put a drain.
You put a drain, right.
Always we put a drain. But bile is very irritant. So there is every possibility at least some of the drops may leak. So at least we can put a drain. But drain is always, is an issue of debate. Should we put or not? But we always put it in. That's it. মাঝখানে মারতে হবে কোনটা দেখি বলো কোনটা দেখেছি স্টিচ ফিচার গুলো এটা কাটি আগে lower end we cut it টাইট হয়েছে না না এটা টাইট হ্যাঁ এটা টাইট হয় ওকে
लास्ट वाला
স্যার এগুলো
इसे पूरा नीचे से
হ্যাঁ 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 দুটোর মাঝে ওকে ঠিক সিজার টাইট করছে টাইট করে দেবে হ্যাঁ ফার্স্ট এর থার্ড এর মাঝে লাগবে দেখ अच्छा
सर आप कहाँ देखो सर बहुत ज्यादा क्लोज हो रहे हैं
এটা থাক আমি যদি দিতে হয় একটা উপরে দেখছি হ্যাঁ কেটে দিচ্ছি ছোট করে দিচ্ছি আমরা একটা উপরে দিয়ে দেবো অ্যাঙ্গেলে ऊपर में दे देगा इसका धर
मनोज दा अरे मनोज दा एक प्री लेबर 2 में हम लोग का एक लैब खुली है प्री लेबर 2 में एक लैब खुली है बोल दी है
Just a small correction from our end. We announced the 25 centers where the live televising is on. We made a mistake of announcing Bhagalpur Medical College. It is Jawaharlal Nehru Medical College, Bhagalpur, and the HOD is Dr. Mrityunjay Chaudhary, to whom we are very grateful for permitting us to conduct the transmission at their end.
Oh, great.
Apologies for the error, and thank you, sir, once again.
Dr. Mrityunjay, we can't speak to him. That is the problem. This virtual issue is we cannot speak to the participants. Only we can talk through the moderators. Okay, so just say hello to Dr. Mrityunjay.
Hello to Dr.
Yeah.
Mrityunjay and to all those participants
Yeah.
who are watching us from all over the place.
Yeah.
We are really grateful to them and we feel encouraged to have more such workshops in the future.
Absolutely. It's very encouraging.
Dr. Kamanas,
Yeah,
there is
please.
one question from Dr. Prakash Shinde of Vasai. He asked, instead of choledochotomy, could we have managed the case by ERCP and internal sphincterotomy?
That we are already discussed.
Already discussed, I know.
We can do it because it's a multiple stone and CBD diameter is 14 millimeter. So we decide we go for a CBD exploration. And Professor Saha cited one of our publication where we have seen that
And also Dr.
there
Shinde
is a reduce of cost, almost 20 to 25% less cost if we do together. And one more I can say,
And he also asks, when will you remove
No.
the stent?
we remove it 3 weeks after. And one more that we say, either our surgeons must learn endoscopy, they must learn endoscopy and do the ERCP themselves, or else better you learn good CBD exploration and do CBD exploration. Why surgeons will depend on somebody else? That is another philosophy I think we should inculcate.
Yeah. There are more and more publications saying that lab CBD exploration is as safe as ERCP. You avoid the ERCP related complications.
Yes.
And it is feasible. If you have a good featuring skill and you have the equipments like a cholecystoscope or a good ureteroscope, it is feasible to have laparoscopic gallbladder and CBD exploration in the same sitting. This is a viable alternative to ERCP. Yes, ERCP is still an option, but surgeons are now switching on to primary surgery of CBD with laparoscope.
There is some place in India, I know some state where surgeons are not allowed to do endoscopy. So what is the viable options for the surgeons? It is their own patient who is suffering. They will do the lab chole. Why not we do CBD exploration and lab chole if the criteria fulfills? Definitely we will not do a CBD exploration in a small diameter CBD.
Dr. Tamanoj,
yes,
there is another question from Dr. Rameshwar Sable of Jalna.
Okay, please.
Okay. Can we take cystic artery with bipolar without running for two structures in critical view of safety?
Definitely, when we are sure that this is a cystic artery, and I know one surgeon who is moderating this session, Professor Saha, who is doing only and only bipolar, using bipolar for sealer for cystic artery. He is not using even a single clip. Probably today morning you have seen Professor Saha is applying clips, and that because we are very keen to ask Professor Saha, sir, don't do sealing in this patient. You put just put a clips and remove. That we divide. Otherwise, Professor Saha. So this is absolutely an option. A bipolar sealing.
Another question from Dr. Ranveer Singh of Delhi. Dr. Ranveer Singh from Delhi, he asked, how often you are doing CBD exploration?
How often?
In short, he has written HOR. So
CBD exploration in a month in our hospital, we do basically 2 to 3 case CBD exploration we do in a month. Mostly our patients we do ERCP. ERCP is, and we have a very good, not only technically, he is also a very good friend of us, who is a gastroenterologist. So we do ERCP followed by lab chole. So that's why we are discussing that we will do in a same sitting, same anesthesia, lab chole, left hand instrument, left hand. Viable option in a same sitting that we are planning because we have a good gastroenterologist.
Patient
because this part will remove, that's why we are we'll put a 400 ml clips, 400 LT 400 in this side to prevent any stone spillover.
Beast number ADK.
Dr. Kirti Pundir from Lucknow.
Yeah,
he
please.
Comments good academic.
Good.
Dr. Priyashi from Lucknow, she also comment how a good session.
Thank you. You just greet everybody. It's a basically it true that we are performing, but truly if really it make any help or any ideas to share with friends, that is more important than.
Professor Dilip Chakravarti comment, thank you Diptendra, the operation is like painter painting on a canvas. Best wishes from Dr. D.K. Chakravarti.
So now we'll finish it.
And Dr. Dilip,
अरे हार्मोनिक का वो दो बैग ले लीजिए.
So we'll complete the rest part of cholecystectomy. And because we have a harmonic, we are doing this luxury. Otherwise, monopolar hook is good.
Dr. Tamanas, Dr.
Yeah.
Professor Dilip Kumar Chakravarti comment, Tamanas, well done. Very good video, good learning for the juniors.
Thank you, thank you. We just send my regards to Professor Chakraborty. And truly, Professor Chakraborty is a person who never missed any single Sasicon, I think, for last 30 years. And this COVID changed the whole world.
Actually, Dr. Manas,
Yeah.
we are moving into hiatus hernia.
Please, please.
Oh.
Okay. Thank you very much, everybody.
Yeah,
Thank you.
Thank you. Well done. Very good demonstration. So we are switching on to next OT with Dr. Om Tatia. We'll be doing a hiatus hernia with fundoplication. Dr. Tatia, with you.
Yeah.
We have a brief about the patient.
This patient, about 23-year-old with severe suffering from severe reflux esophagitis and hiatus hernia. The endoscopy says hiatus hernia. The OG junction is about 35 centimeter from the incisor, and the manometry is also suggestive of hiatus hernia. So we have taken this patient for fundoplication. Okay.
Yes.
We always do manometry in each and every patient suspecting of hiatus hernia or GERD. Number one. Now, as far as the operating part is concerned, the patient is under general anesthesia, endotracheal intubation, and the patient is in French position. I am standing in between the leg. The optical port, since the patient is a very short statured patient.
Show the external view in full screen.
External view.
Yeah.
External view.
Yeah.
So the optical port is infraumbilical. Normally, I keep this optical port about 18 centimeter from the xiphoid process. Right hand working port. This is my right hand working port. This is subcostal, about a centimeter, 2 centimeter below the costal margin, right mid-clavicular line. My left hand working port is in the right mid-clavicular line, about 2 centimeter below the costal margin. This is another port in the left anterior axillary line. This will be for retraction. I put the Nathanson's retractor. You can see that Nathanson's retractor. Inside you can see the Nathanson's retractor, which is already retracting the left lobe of the liver. Nathanson is a very good retracting device for the left lobe of the liver, especially in the upper abdominal surgery. Now, this is with this port position and position. This is the Kussner's window you can see. This is the Kussner's window. This is the caudate lobe of the liver. This is the Kussner's window. I gain access into the lesser sac by opening this Kussner's window. I gain access here by opening the Kussner's window. Go on opening it. Go on opening it. Here a point of caution is when we are incising this peritoneum, this is the position of the diaphragmatic hiatus. You can see the right crust. Our incisions should go like this. It should never go in this direction. If we go in this direction, there's a possibility we can injure the inferior vena cava. I will show you where is the inferior vena cava. It will be there, so there is a possibility that we may injure. In fact, I have seen a video where inferior vena cava was injured, where the surgeon went in the wrong direction. So I go on opening it. Go on opening it. Now I take a turn. Take a turn. Now come here. I come here. And join this incision with this. Then I go on this side and divide these fibers which attach the fundus of the stomach. This is the inferior phrenic vessel, you can see that. And now I once made this incision, this is the right crus of the diaphragm, you can see that. Can you see?
Yes, it's very clear. It's very
so
clear, yeah.
I make an incision on the peritoneum just medial to the lateral to the right crus of the diaphragm.
Yes.
And this incision very superficial only onto the peritoneum, and here we have to be careful that we don't strip off the peritoneum from the right crus of the diaphragm. This is the esophagus, you can see here now. This is the esophagus. I'll lift the esophagus along with the posterior vagus. I'll show you the posterior vagus very soon. Now, this is the left crus of the diaphragm. Can you see that?
Yes, yes.
So I go on creating this tunnel behind the stomach.
Yes.
That's the posterior vagus. Can you see?
Yes, absolutely clear. Very
posterior
clear.
vagus.
Very clear, yes.
So the posterior vagus is always lifted. I think the posterior vagus has got, oh, there's the vessel. Take. So I create a window here.
Yes.
Can you see this window now?
Yes, yes, we can see. So basically you're going from the right to the left and making a window. So you're encircling, you're going behind the posterior aspect of the esophagus totally.
Yes, very right.
And
very right.
So you can loop the esophagus whenever required. So the people who don't have Nathanson's retractor, how can they retract the liver?
You can retract the liver by anything. You can retract it with a needle holder. So,
but I don't think you can get such a good exposure as you get with
Nathanson is a very good retracting device.
Yes. Yeah.
Excellent. And once you have connected it to the Nathanson, you have put the Nathanson in position, then you can forget about it.
Yes. True.
That's the best thing about Nathanson.
Yes. Yes. So now you are working on the anterior aspect.
I'm working on the anterior aspect. I'm trying to create that window.
Okay.
This window, I'm trying to gain access there.
Yes. But some people who were doing, who have a gold finger often take a gold finger.
Yeah, you can use a gold finger.
Gold finger. And
see, what I'm doing is everything I'm doing under direct vision.
Yes, yes.
नहीं ये तो inferior phrenic artery है ना. This inferior phrenic artery. I'm not going to disturb this inferior phrenic. This inferior phrenic. I can divide this.
So what is that vessel which
that's inferior phrenic.
So you can divide that.
Yeah. See, you can see here. This is inferior phrenic.
Yes.
Okay. If necessary, I can divide this branch, which is holding my stomach.
Okay.
That's a branch to the stomach. Fundus from the inferior phrenic. It can be very safely divided without any problem.
Okay, okay. Right.
and it's a big window that I'm creating.
Yes. So you have a good wrap and you can
Yeah.
sort of bring the stomach pretty well.
And it's a good idea to lift the esophagus with a feeding tube or with a
You can use an umbilical tape or
umbilical
feeding
tape is not available nowadays.
Okay.
So we have to use a feeding tube.
Okay.
Very patulous hiatus. So we'll put a feeding tube inside
Ah.
to lift the esophagus up.
So don't you take the short gastrics?
Short gastric I will be taking.
Okay, after you loop the esophagus.
Yes. I need to mobilize a little more.
Okay.
There's a feeding tube I have taken. Earlier we used to get this umbilical tape, which is not available nowadays.
Okay.
I don't know why gynecologists are not using umbilical tape anymore. Don't tighten it completely. It has to be very loose. So that we can slide it up and down across the esophagus.
Yes.
Okay.
Yes. So you basically put 3 throws.
Yeah.
3 throws. Yeah.
So you hold it, not the thought. Not. Yeah. Okay. Very light.
So this is your right axillary port.
Yeah, this is coming from anterior axillary port.
Yes.
Anteriorly. You put a lift. Yeah, very good.
So that's a very clear demonstration of both the crura. So which is very, very important. You need to demonstrate both the crura very well. But you said something about not taking off the peritoneum from the crura.
The reason being when we are doing cruroplasty,
Yes.
the sutures, if you strip the peritoneum off,
Yes.
the crural muscles may not hold the sutures.
Yes. Okay.
So we see very painstakingly I'm trying to preserve that inferior epigastric. If necessary, I will divide.
Okay.
So we have done almost a complete that's the abdominal aorta you can see.
Yes.
Niche.
So the abdominal aorta is between both the crura.
Yeah. See, this is a good technique to learn transhiatal esophagectomy.
Yes.
Asti. Very good way to learn transhiatal esophagectomy. This is not Vegas, don't worry. I'll show you the Vegas. Can you see the anterior Vegas?
Yes, yes.
Okay. So I'm not at a
So there are some people who don't take down the short gastric. When do you don't take the short gastric and why?
If I find that the fundal wrap is coming nicely without any tracks, without any tension,
okay,
then I don't divide. But I always divide. I'm yet to, and I mean, last so many years, I have not done a single case where I've not divided the short gastric. So we have got a good intra-abdominal esophagus. Do you agree, Ramesh?
Yes, 100%.
And
so
this is the right crust. If I show the anatomy once again, this is the right crust, this is the left crust, this is the inferior phrenic vessel, that's the abdominal aorta down there. and you will find celiac trunk. You will find celiac trunk here. That's a
Yes.
location of the celiac trunk.
Yes.
Can you see that? Here you will find the celiac.
Yes. Yes.
There you will find the celiac trunk. So now this part being over, now we will divide the short gastric and mobilize the fundus. Come here.
So any particular reason you're parking the gauze there, or just you're parking it there?
I'm just passing it there.
Okay. Okay.
Uh, out of practice or out of
No, take
habit.
care.
Because it was lying here, I'm going to operate here. So,
Right. So any tips of approaching the short gastric?
yeah, I'll tell you. See, this is the greater curvature,
Yes.
and this vessel, I will try to gain access into the lesser sac from this point, because my idea is to divide the superior most short gastrics.
Yes.
So unnecessary, I don't want to divide many vessels of the greater curvature. There's no harm in dividing.
But why should you do it unnecessarily?
Yeah, unnecessarily. Why should I do it?
Why do it? So sometimes you get, you cannot get into the lesser sac. You have difficulty in getting into the
Yeah,
lesser sac.
you may have difficulty.
If the patient is very obese or there is too much of
Yes.
fat there. So, Dr. Tatia, you'll make it look so easy that even a beginner will say, "Ab bhi main karta hu."
Thank you. It
Yes.
is an easy procedure. It is not a
In
difficult
in hands of Tatia. He's a man with golden hands.
See,
The more I see you, Dr. Tatia, the more I admire you.
Thank you very much.
And if you're a girl, I would have proposed to you. Anyway, let's carry on the work. Sorry. Yes, so you're trying to get the opening, yeah.
So I got the opening now.
Yes.
I got the opening now.
Yes.
See, it's good to see both anteriorly and posteriorly do a harmonic clipping of these vessels. We don't want these vessels to bleed and spoil the field. So see both anteriorly and posteriorly, do harmonic clipping and then divide.
Yeah, so that's a very important point to note, that what you've not done is gone straight with the harmonic. You've coagulated both sides and then taken in the middle, so that there is no scope of error of bleeding. Because if you have bleeding here, you're in a real spot.
No,
Real spot. So God forbid, if you have a bleeding at this area, then what do?
Sorry?
God forbid, if you have a bleeding in this area, then how do you go about it?
I will call Ramesh Agrawala.
I'll call. Oh, boss.
Patient tied with এটাকে স্টমাকটাকে মিডিয়ালি পুশ করে yes that's better यहाँ दिखाना শেষে See, Ramesh, the only way to avoid bleeding here is stick to the basic principles.
Yes.
and there is no scope of any hurry, any
Yes.
loss of patience. There is just no scope.
Yes.
You can see the stomach is adhered to the spleen. I have to be very, very careful
Very, very careful.
and have to release it from there.
Yes.
Sometimes what you have to do is, sometimes you have to come from above, come from below, again come from above, again come from below. Like that you have to make.
Yes.
So thoda upar se, thoda niche se, something like that.
Yes. So basically you have to improvise
Depending upon the
situation.
Yes, yes. Okay. And another trick is, see, my colleague, he is pushing the stomach medially down there, and I am holding the stomach here and pulling it medially.
Yes.
So I cannot afford to have any bleeding at this position.
True.
Some dissection from this side, some dissection from that side, and that is how we have to progress. Small tissues. And remember, Ramesh, the posterior short gastric, posterior superior short gastric is the most notorious vessel.
Most notorious, yes.
Because that's really short and that's a really big. So if any bleeding from that vessel, that's torrential bleed.
Yes.
So I think my mobilization is complete.
It's
If you can
absolutely perfect. Absolutely perfect.
see, if, you can see my mobilization. Stomach is perfectly mobilized.
Perfect, absolute.
So if I look here, if I look here, there is no hindrance to the, yeah, etake chap santosh, etake chap sasi. There is absolute mobilization.
Yes, true.
I will check it from this side also. The next thing I do is I put the stomach in the anatomical position, ask him to hold it, and
you do the crural repair.
And no, before that,
okay,
I check whether my mobilization is perfect or not. See, I brought the fundus from behind, Maryland. I brought the fundus from behind the esophagus.
Yes.
And this is called shoe shine maneuver.
Yes.
And it is very easily coming.
Yes.
I leave my left hand grasper and the fundus is not going back. That means my mobilization is correct.
Correct, yes.
Now I will repair the crura. I think I always are on the side of the loose crural repair.
Okay.
Because dysphagia is the worst thing to happen to these patients. And contrary to the normal belief, the dysphagia more often happens because of the tight crural repair rather than the tight fundal wrap.
Fundal wrap. So you always do a 360-degree wrap, or?
Yeah, that's my choice.
Yes. Okay.
Some people, they do a 270-degree.
Yes.
I do 270-degree only in cases of achalasia cardia. When I'm doing a fundal wrap associated with achalasia, my choice is 270-degree.
Okay. Okay. Achha, you are bringing the posterior wall of the fundus. How can you be sure you are bringing around the posterior wall?
I will show you. Let me make the crural repair, then I will show you.
And what is the suture you are using? Ethibond.
This is Ethibond. 20 Ethibond.
20.
Yeah. Yeah.
Do you
see the advantage of keeping this peritoneum this will hold the suture. Otherwise, this muscle tend to tear.
Do you use V-lock suture?
No.
No.
For this cruel repair?
Yes.
No.
Yeah.
Because my suturing is interrupted.
Yes.
So
there is no reason for a V-lock suture. Yes.
I don't find any reason to use V-lock.
Yes. They've done manual.
See, when you are using a Ethibond, you have to use 3 throws. You have to use.
Why 3? Why not 2?
Because it tends to loosen. The 2 throws, when you are tightening it, it tends to loosen. So I take 3 throws.
Ethibond is a very good suture.
It's a very good suture material.
Very good handling properties and very good. But this is 2-0 or 2?
2-0, 2-0.
2-0.
It looks thick on magnification.
Okay, okay. You'll put another suture now?
Let me check.
Okay.
Because as I said, I always are on the side of keeping a loose crura rather than a tight cruel repair.
Okay.
Because this is something which is absolutely unwanted.
Okay.
See, there are different ways of making sure that the wrap is tight or loose. If you lose this, if you leave this esophagus,
yes,
and if it fits very snugly into this, I mean, just fitting right, I think it is okay. So I may give one suture here, not here, here. Okay. Or even if I leave it like that, that's not an issue. But one suture I will put there.
Okay.
I'll put one suture here.
Do you always advocate a non-absorbable, or can you use the absorbable like Vicryl?
Always non-absorbable.
Always not.
Yes.
And any other suture choice except Ethibond?
Very good. Now I bring the fundus from behind. This is the fundus. Pull. See, Ramesh, show me here. Show me. Yeah, this is the anterior wall.
Yes. Okay.
This is the anterior wall,
Yeah.
and this is the posterior wall. This is the point where omentum was attached.
Okay.
So fat, posterior wall, anterior wall. I
Okay.
pull the anterior wall. I can see the anterior wall, and that's the posterior wall. Posterior wall is a little more shiny.
Okay.
So now the next thing I do is I put a wrap like this.
Yes.
So see, idhar se. I take this. So I make a mark here.
Okay.
So that I can. Needle holder there. Rise to. I take a mark there so that I know where I have to take the stitch.
Okay.
I always take the superior most stitch the first. Okay. And the stitch should be on the anterior wall, on the left side, and on the posterior wall on the right side.
Okay.
That is Santos A. See, it is coming very nicely.
Yeah, perfect. Absolute. Absolute. নটটা ধরবি
I'm just taking the knot. I will slide it to my appropriate position.
Okay.
Knotটা ধর very good. এই বদমাস ঠিক আছে ইধর নিয়ে কাজ কাট আরেকটা সুতো I'll park this needle and take one more.
Yes, it's a short thread now. Yes.
Another 5 minutes, we should be over.
Yes. So what do you do? What is the advice in the post-operative period?
See, one thing very important that we have to tell to the patient. See, this patient will take orally from tomorrow morning.
Yes.
And will go home tomorrow morning.
Yes.
Small piece of advice to these patients is we have to warn them about possible transient dysphagia.
Okay.
That is very important. Because if they know from beforehand that there is a possibility of transient dysphagia, they don't complain to you much.
Okay.
Secondly, I always advise them against taking any aerated drink.
Okay.
এটাকে ধরে নিচে টান. And rest, nothing big.
So do you keep them on liquid
Acha,
diet?
Ramesh, now see, this
Yes.
was my superior most.
Yes.
Now I slide it up,
Yes.
take a bite,
Okay.
take a bite here
Okay.
and slide it up because I want to take a bite on the esophageal,
Yes.
take a bite on the esophageal wall.
Yes.
And this bite has to be a little onto the right because the left vagus, anterior vagus is towards the left side.
Okay.
So this bite comes here and another bite here.
Okay.
So this avoids taking a bite on the anterior vagus. Oh no, I made a small puncture here. So sorry. And so sometimes 2 stitches, sometimes 3 stitches are good.
Yes.
I think if you take a short wrap, then
Yes.
2 stitches are good.
Good. Yes.
If you are in a habit of taking a bigger wrap, then 3 are good.
Yeah.
I think this is adequate.
Perfect. Absolutely perfect. So would you fix the wrap to the right crura?
Yes, I always.
Okay. So these
Suta.
are the things which we do to prevent migration of the wrap. One is take one of the sutures through the wall of the esophagus, and second, tack the wrap to the crura.
So I think my job is over.
Perfect. Perfect.
I will fix the wrap to the right crust.
So
I'll fix the wrap to the right crust. Another 2-3 minutes job.
So do you put the patient on liquid diet for a few days? Do you?
I'll put the patient on liquid diet tomorrow. Day after tomorrow, semi-solid, then normal diet after 2-3 days.
And do you give any prokinetics to them?
No, nothing.
There is no prokinetics. So there is nothing special in the postoperative period,
No.
except just telling them about the transient dysphagia.
Yeah. And now
what would you mean by transient dysphagia?
Transient dysphagia means the patient may experience some degree of dysphagia which is self-limiting and passes of its own.
Okay. So what
we have to reassure the patient about this dysphagia. What I tell the patient is see, earlier you had a loose junction, so acid was coming up, and similarly food was also going down without any resistance.
Yes.
Now we have tightened it so that your acid doesn't go up. So similarly, you will have some resistance to the food, which is the normal thing, and you will become habituated of it.
Right.
So this is how I counsel the patient.
Okay. So I think, Dr. Tatia, this has been an absolute pleasure moderating this session.
Thank you, Ramesh.
And
thank you very much.
It's real.
I'll be more than happy to take any question.
Copybook. I don't think there will be any questions because the way you explained everything. I just have a look at the questions, but you've taken everything in details. So I'll just have a look at the questions.
ঠিক আছে করে নিচ্ছি
So there is one comment that the
Yeah.
hands of Tatya sir, even posterior short gastric artery is not going to be notorious. What we call the golden hands. He's repeating what I said. Then there is Prakash Sinde. He says, how do you choose Nissen or Tupe and why?
See, normally we do a manometry, and if in manometry we find that the patient is having any this motility disorder, then we go for Tupe.
Otherwise, you go for a complete trap.
Yes, yes. That is
And
our standard practice.
what should be the length of esophagus dissected proximally?
See, I want at least 3 to 4 centimeter of esophagus intra-abdominally.
Is there any landmark to prevent damage to posterior vagus before creating the windows?
See, if your dissection stays close to the 5 millimeter नहीं है ना?
To the crura.
Yeah, just a minute. 5 millimeter scope नहीं है. अच्छा, दे देखिए एक बार हमारे. आ गया. नहीं आएगा सुशील, नहीं आएगा. It's angulation is इधर से आएगा. मेरे को इधर से दे. Just Ramesh, give me 1 minute.
Okay, okay.
Yeah. हाँ, टोकन निकाल. निकाल. So you've taken the gauge out by a railroad method.
Gauge out.
Yeah, what was the question, Ramesh?
No, I will tell you. Is there any landmark to prevent damage to posterior vagus before creating the window?
See, if you lift the esophagus from the right crush of the diaphragm, I mean, staying close to the right crush, you will always see the posterior vagus stuck to the esophagus.
Do you put a drain?
No. We have not put a drain.
What is the difference in port position in case of a short-statured person?
See, this patient is a very short-statured patient. So my optical port normally the optical port remains about 18 centimeter below the xiphoid process.
So I think
it is usually supraumbilical, but here the optical port is infraumbilical because the patient is short-statured.
Yes, you did mention that 18 centimeters, which is there, that is your landmark. So depending whether the patient is short or big, if it's big, it will go supraumbilical. If it's short, it will go to infraumbilical or umbilical, whichever position is there. So that is the thing.
And it is 1 10 millimeter and 3 5 millimeter ports.
Yes. So there are a lot of congratulatory messages.
Thank you, Ramesh. Thank you so much.
Thank you. Thank you very much. I think we've had a very, very good session. I think you deserve a very big round of applause.
Thank you. So we have completed. Only one case left now.
Two cases.
Thank you.
Marker placement.
Huh?
Marker placement in the breast and thyroid.
Okay. Marker placement patient भर्ती हुआ नहीं तो पीछे
Very nice.
So now we are waiting for the total thyroidectomy OT. Surgeons Dr. Makhanlal Shah is just getting ready. In the meantime, we are just taking 1 minute break and then we are coming back to the OT again.
Just give you a brief outline of the thyroid patient. Regarding our thyroid patient, she's a 60-year-old female, swelling in the thyroid region, insidious in onset and gradually progressed over the last 15 years. No history of any pressure symptoms like dysphagia or hoarseness or respiratory difficulty. Biochemically, she's euthyroid. On local examination, there's a 9x6 swelling over the thyroid region, firm in consistency, lower border palpable, no cervical lymph nodes. High resolution USG shows a 73x53 millimeters, well-defined heterogeneous hypoechoic SOL in the left lobe and part of the isthmus, having solid mural nodule and cystic spaces, thyroids 4. Subcentrometric lymph nodes in the bilateral cervical region. CCT neck done, which shows the left lobe of thyroid enlarged, well-defined heterogeneously enhancing hypodense lesion, 94x67 millimeter in the left lobe of thyroid. No local invasion, no significant lymphadenopathy. Trachea mildly compressed to the right, sorry. FNSE shows an adenomatoid goiter. The plan is a hemithyroidectomy. Patient will be operated on by Professor Makhanlal Shah and will be ably assisted by Dr. Siddharth Mishra and Dr. Milind Alokji. So we are just waiting for the patient to be anesthetized. Once we are through, we'll take you over to the OT.
এটা সেট হয়ে গেছে।
Anesthetist का complaint है, you never mention about anesthetist. इसका भी नाम ले
अभी Has sir got his mic? We are in OT3 now. Since morning, we've been having one case after the other. Extremely smooth transition going on in the OT. All thanks to Dr. Takia and his surgical team. But we'll be making a big mistake if we don't mention that we have a very good team of anesthetists led by Dr. Namrata Biswas. Not to forget all the OT sisters, the technicians, and the support staff who are giving us immense support since morning. A big round of applause for all the OT staff, sisters, anesthetists, and obviously the surgeons led by ILS team, Dr. Tatia. We are in OT3. We are just draping the patient. The patient is being draped now. We'll start in a while. Right. Sir, do you have your audio on, please? Professor Shah?
Yeah.
Right, yeah. Sir, if you can just talk us through the positioning of the patient before we start.
This is the standard position for thyroidectomy. Patient is supine with a sandbag in between the shoulder blade, head resting on a head ring and up by 15 degrees. The neck is extended. So you already listened to the summary of the case. You can find there is a multinuclear goiter involving the left lobe thyroid gland. The right lobe is normal. Clinically also, there is no enlargement on the right side. And we have ultrasound and CT corroboration of the finding. So FNAC shows adenomatous goiter. So you have changed our plan to do a hemithyroidectomy instead of total thyroidectomy.
Right.
So
though it is a large lobe, the lower border is well palpable.
Yeah.
I think the anesthetists had their concern about whether there was a retrosternal extension.
No.
But both clinically as well as radiologically, it's proven that it is totally in the cervical region and there is no retrosternal extension.
Yes, marker. So we just get some landmarks. These are suprasternal notch. Hey, bhalo pen do, sister. Bhalo pen do. So this is the suprasternal notch. This is the midline. This is midline. And this is the upper border of thyroid cartilage. So this is the thyroid cartilage upper border, suprasternal notch. Give me a silk thread. The standard incision is classically described as 2 finger above the suprasternal notch. But if a large goiter, you can go little above. Okay, it's not necessary that it be always 2 centimeters above the suprasternal notch. So here is a large goiter involving up to the almost the upper pole. So you go little higher up. So we make a marking with the thread.
I think this is called garroting.
Yeah, garroting.
Yes, garroting.
So as will be hemithyroidectomy, we'll just keep the incision confined to the anterior border of the opposite sternum side. So we'll start with the.
Sir, our lady is a very short-statured, thin lady.
Yeah.
But in case of obese patients also, sometimes we take the incision a little higher.
Yeah.
Because later, due to the pull of the breast tissue, the scar might come down over the suprasternal notch. But here is a very thin lady, so I think we can go with the traditional approach.
আমার হার্নিশন নেই বাইপোলারের সিলারের সন্তোষকে বলো
Dr. Shah sir,
yeah.
Do you inject normal saline anytime for taking the planes?
No,
Sometimes
no. The plane is not difficult. I'll show you the planes. It's not necessary.
See, the vessels in the subcutaneous plane, the subplatysmal plane are very small now. So usually those who do it, they're apprehensive of bleeding. So not only normal saline, it is usually an adrenaline in normal saline that is injected to raise the blood.
বলো ওখানে গিয়ে বলো নয়তো মাথাগুলো তিনটে মাথা এক না করে মাথা এক জায়গায় ক্যামেরা দেখা যাচ্ছে তিনটে মাথা এক জায়গায় পজিশন
Requesting the camera person to zoom in. Right.
Yeah. Skin hook data, sir. These are plasma. You can appreciate
Yes.
the plasma.
Yes, sir.
So inside the plasma, it is higher than the skin incision.
So we are raising the subplatysmal flap.
Yeah. Yeah. Okay.
See that it's perpendicular. So do you prefer using skin hooks in during this dissection?
Yeah.
I think you'll get a better traction in that case. That's fine, absolutely.
আমার ইনস্ট্রুমেন্টটা পেয়েছো সিস্টার? সিস্টার আরে আমি একটা ইনস্ট্রুমেন্ট দিয়েছি, সন্তুষ্ট বলো? প্যারাসেভে দেওয়া আছে।
Being a large thyroid, how far will you be raising the superior flap?
Up to the upper border of thyroid.
Upper border of thyroid, okay.
So if you're on the right
Think-
plane, it's a
yes.
bloodless plane.
Yes, sir.
There's no bleeding at all.
The only vessels which might be encountered at this point are the anterior jugulars.
Yeah. So you are almost to the upper part of thyroid cartilage.
Yes.
Come to the lower. So we'll
The
raise the
upper
lower
border
flap.
has been raised, yes. মাঝখানে আনতে হবে। I think you've reached the suprasternal notch.
Almost.
Yes.
So these are suprasternal notch.
Yes, sir. Yeah.
So
Again, if you're in the right plane, this is an absolutely pristine plane.
yeah.
There's no bleeding should happen at this time.
Yes.
Yeah.
So it should be a soft latissimal dissection.
Yes.
You can use even a scissor or a scalpel blade to dissect this area.
Right.
But I am comfortable with the. Next is again you have already marked the midline. You see the midline is little pushed here to the right. Okay. So there's a suprasternal notch here.
Right.
So I believe the midline might be here. Yeah. Sometimes I use the Jones retractor for just retraction. Just see how it works.
But isn't it a bit of a, because it's a big instrument, does it not obstruct your field when you fix the Joule's retractor?
No, sometimes I found it very convenient.
Okay, sir. But otherwise, do you commonly go for the silk stitch to raise the flaps?
Silk stitch or sometimes no retraction is required. Just
right.
Langenbach's will do. Yeah. Hello, sister. George. This is one antejugular vein.
Yes, sir.
And this other side, and the other side saying this midline might be here.
So the midline is not very clear, isn't it? Because of the large.
Actually, you see the large left lobe.
Yes.
Pushing this to the right. So this is the area of midline. This one.
Sir, in such large glands, what are the points to be kept in mind for identifying the midline?
You take the bony landmark. You find the suprasternal notch.
And the
you find the chin if it is the straight, and then join these two lines. That gives you the midline idea. So I believe this here the.
So if you try to go from the neck, it may not be easy. So we have to go above from the suprasternal notch or below from the mentum to track the midline.
Now, if it is a very large gland, there are two options to start these strap muscles. Either you can retract it as you do, or you can divide it. If you divide little higher up because the nerves are entering from below.
Right, sir.
So you see, I am in the right midline, but you see
Right,
there are
sir.
very large vessels on the surface.
Yes.
It's a very vascular gland. Now is the once I have done this, I have to lift the strap muscles. Yes, you see there are two layers. These are superficial layer, and these are deep layer. Okay, this is my hand instrument.
So will you attempt to dissect the strap muscles of the thyroid?
Yeah. I will
Yes, sir.
dissect and incise the pretracheal fascia over it.
Okay, sir.
So.
So a lot of our junior residents, they have not seen a Joule's retractor being applied. So
Yeah.
it's a good experience for them. Because many centers do not have a Joule's retractor. So what energy source are you using, sir?
This is a bipolar. This is a diathermy having unipolar, bipolar. A bipolar and a bipolar sealer.
Okay, sir.
So I hope to go with the bipolar sealer system, and I hope I
So
did not.
basically one instrument should suffice for everything.
Yeah.
Okay, sir. So you're opening the fascia now.
Yeah.
Yes.
I am taking the strap muscles off. These are superficial layer, and you can appreciate the deep layer of sternothyroid due to this layer. This is the deeper layer.
Sometimes in large goiters, this plane tends to get a little messy because of the dilated vessels there.
Yeah. This is a hand instrument which has got a reach, so it both seals and cuts. Very vascular gland.
So is the muscle coming off freely?
Yes.
Or are there additions
Yes.
with it?
No.
Yes, okay.
I can strip off easily, but there are a lot of veins on the surface.
Yes. And
Very
the
vascular.
point is because the veins are so stretched over a large gland,
Yeah.
it's often not well visible. I mean, you only understand it after you've nicked it and it's bled. So we have over 2,800 participants logged in now.
Oh, that's great.
Yeah. Extremely encouraging numbers.
I have a doubt whether such large vessel will be taken by this bipolar device or not.
Exactly, sir.
Let's see. Give me right angle first. Oh, something.
I think you're reaching the lateral aspect of the left lobe now.
Yeah. You see the IGV is test. This is IGV.
Yes. Can you please zoom in? Camera person, can you please zoom in? So could you point out the IJV once again?
Yeah, this one.
Yeah, right, sir. Yes. Blur हो रहा है.
Fine, so that's it.
Another very big vessel stretched across the
Yeah.
gland. So do you plan to take control of it before further dissection?
Yes. I have to split the critical layer of the fascia.
Yes. So the energy source that you're using, till
Yes.
what size vessels can this tackle?
This can seal up to 7 millimeter
7.
vessel.
The vessel that you're dealing with now seems larger than that, isn't it?
Close to that.
Close
not
to
very
that.
large.
Okay.
This is the peanut though.
Please zoom in at the surgical field, please. Yes, please.
এটা finish the funny thing. Back చేద్దాం చేద్దాం చేద్దాం
Sir, will it be necessary to take a stitch? Sir?
Yeah, I'm taking a stitch.
I think that will be better.
Hold it. Detectable.
Sir, have you reached the left border?
Yeah,
Yes.
I have reached the lateral
Yeah.
border.
Can you see the middle thyroid?
Yes,
Yes.
yes. Yeah, right angle. This is the middle thyroid.
Middle thyroid. Yes, sir.
Nice. I hope this will see it up.
Sir, are you using the monopolar mode or the bipolar mode?
It's a bipolar
now?
sealer.
Bipolar scissor. Okay.
It's a bipolar sealer. Now, once you take the middle thyroid, the option is either go to the upper pole
Yes.
or to the lower pole.
Right.
So I'll go to the upper pole first.
Okay, sir.
Come. Pick the top.
I think your
Yes.
assistants have to retract well. It's a large gland.
So we have a good number of large vessels.
Yes.
So we should take the medial border of the gland. This will open up the reed space.
Yes.
You can appreciate the vein at the upper pole. This is the upper pole. You see? So I hope my sealer will take this artery. You see this artery is pulsating?
Sir, if you can just slow down a bit, we are not getting a good visibility. Camera person, you are requested to please focus at the point of surgery
Yeah.
here. So we are not able to see what you're doing. So just
Give me the right angle. Right angle though. Pull. Can you appreciate the artery I have taken?
Sir, your fingers. Yes.
This is the artery.
Yes, sir. We can see it now. Right, sir.
I
Yeah.
will go this artery and the vein separately. I hope my sealer will take this.
So you're using the maximum mode with the bipolar scissor,
Yes,
right?
it's a
Yeah.
bipolar sealer.
Right, sir.
Dr. Shah sir,
Yes.
can you show us the parathyroid?
Not now, I'll show you.
Not yet, huh?
I'll show you. Let me feed a superior pole. Pull it. You can see the nerve. This is the superior nerve. You see?
Sir, a minute, please, sir.
This one is superior nerve.
So just hold on, sir. We'll try to focus in your field once again.
Yeah. This is the nerve. This one. And we have taken the artery. Now we're taking the vein.
Sir, can you show it to us once again?
Yeah.
Yes, sir.
This is the nerve. Can you
This is
appreciate the nerve?
the external branch of the superior
Yeah.
laryngeal, right,
Yes.
sir? Yes,
Yes.
sir.
Now we'll be taking the upper pole. Right angle.
The assistant's hand is in the way.
Yeah.
So that, can you just lower your finger? Yes, that's much better. Thank you. So you had taken the vein or the artery when you?
I have taken the artery first.
Artery first, right, sir.
It is better to take the artery first. If you
Yes,
take the vein first, the vessel will get more engorged.
More engorged and congested, right, sir.
Now you have taken the vein.
Vein.
Yes. I hope my sealer will take this. Yeah.
Siddharth, can you suppress the gland a little so that we can get a better view? Yeah.
So now then I have taken
So the superior pole is free now.
Yeah. And the trick is you should be close to the capsule of the gland. Okay.
Right.
If you are close to the capsule of the gland, other things will go more lateral.
Right,
Okay.
sir. Right. So you will be turning it medially now.
Yeah.
You look at the posterior part.
Now is the time to show you the parathyroids and the. Peanut, this is the peanut. Now I'm coming to the lower pole of the gland, and here you have to dissect the.
So the visibility is not good, so we'll just request the camera person to focus in.
Yeah.
You're going through the capsule, sir, right?
Yeah. Here comes
Right,
the
sir.
branches of inferior thyroid artery. With this amount of vascularity, I would have preferred a frozen biopsy.
Absolutely, sir. Yeah.
Because it is looking like malignant.
Though we have an FNA saying it is an adenomatoid goiter,
Yeah.
but the USG says there is a solid component also.
So let's see.
Yeah, we'll have to follow up the histopath.
Yeah. Unless it is infiltrating the.
The strap muscles were free, isn't it, sir? There was no.
Yeah,
nothing
strap
in-
muscles are free. Yeah.
Right, sir.
We remain close to the capsule of the gland.
So do you routinely do the intracapsular dissection first or do the tackle both the pedicles and then come to it?
I actually often go by lateral approach where I find first tackle the pedicles all.
Right, sir.
Yeah. You see, this is a region of superior parathyroid. So I'll keep close to the capsule of the gland.
So we have another case ready in the other OT where they're going to do a marker placement. And,
Yeah. You can go there.
So
and get.
we'll keep you on the PIP, sir, and we'll switch to the other OT for a while.
Yeah. Yeah.
Obhiram, we are with you. Can you lead us to the case? What is the patient scenario? OT2, Dr. Obhiram. Is the audio with Dr. Obhiram?
Hello, can you hear me, Samita?
Yes, yes. What is your patient, please? Can you give us a brief outline of your
He is a
patient?
52 years old female patient presented with a big lump in the right breast. And if you look at the breast on examination, there is nipple retraction, PUD orange appearance, also involvement of the skin. It's a big lump in the central quadrant.
Yes.
And our plan is to take true cut biopsy from the lump
Right.
and placement of a marker in the center of the lump.
Okay. So
Okay.
obvious planning is depending on the histopath, you will go for NSCT, right?
Yeah, right.
Okay, right.
And I just want to show you the gun for true cut biopsy. This is 16 gauge but true cut biopsy gun. And you can see the needle after pressing it. And now you have to just take the needle back and just fire it. The biopsy will come within this slot. Okay. Now we are starting to take the true cut biopsy now.
Have you infiltrated local anesthesia already?
We have given local anesthesia.
Yes.
And be careful during the planning of the small incision through where you are taking the biopsy, and it has to be in a place where you can place the incision if it is a malignant. And once again, I am telling you, actually the marker should be placed once the biopsy report is confirmed that it's malignant. Here, the biopsy report is still not confirmed, but clinically, though it's confirmed, that's why we are placing over it. But after only confirmation of the biopsy report, central marker placement should be done. Okay. Okay. Now we are starting to take the true cut biopsy.
I think the point to be remembered is that the needle should not be, should be more horizontally oriented and not vertically downwards, because there can be an inadvertent puncture into the chest wall and into the pleura if it is a vertically oriented needle.
Yes.
And how many cores are you planning to take?
You saw it. You can see the strip of tissue.
Yes.
Within the needle.
Right. That's an handsome core, but how many cores are you planning to take?
I usually take minimum 6 to 8, if not less than that.
So just for the trainees, you have to remember that once the tip of the needle has entered the mass, then only you are going to fire the needle, fire the gun.
Then you should go through different direction.
Yes.
Okay.
Turn the needle, the skin incision remains the same, but you turn the needle in different directions and take cores from different parts of the lump.
You can see the strip. It's a beautiful strip.
Yeah. These questions have been addressed.
Again, a good strip.
Obhiram, we'll come back to you. We'll just go to Dr. Shah's OT once again.
Sure.
I think he's tackling the lower.
Sure. When we will place the marker,
We'll come back to
that.
Yes,
Okay.
yes.
Sure.
You can appreciate the recurrent nerve here.
So we are back with you, sir.
Yeah.
Sir, have you tackled the inferior thyroid pedicle?
Yeah,
Okay, sir.
few branches.
Yeah, multiple branches. Okay, sir.
This is there is some displacement. That's why the goals of the system.
Zoom in করুন, okay?
Hold this.
So if the bleeder is very close to the recurrent laryngeal, one option is obviously that you use a bipolar.
Yeah.
But is there otherwise can be you put an adrenaline gauze, soaked gauze and
Yeah.
wait for some time?
But this will be just a pressure pressing.
Bit of pressure is okay. Okay.
A lot of veins coming from the surface.
It's a very vascular lobe.
Yeah.
What you've shown us is a very, very vascular thyroid.
Right angle. You see, there are few dilated veins, but right lobe appears normal.
Right,
Okay.
sir.
You can appreciate the right lobe here.
I think as per the USG, the goitrous changes had extended into the isthmus.
Yeah.
Intraoperatively also you have the same feeling?
The isthmus is normal. You see, this
Isthmus is normal.
Yeah.
Okay.
Actually, the left lobe was projecting to this side.
Okay, sir. Okay.
Yeah.
I think there is another big vein there.
Yeah, yeah. But this bipolar will take. No, this particularly on that side. This is the branch from the inferior side. This is the isthmus. Yeah. Yeah, right angle. Here, this is the
So you're
separate.
dissecting the isthmus now?
Yeah.
Yes, sir. Fine. Sir, we'll just shift to the other OT for a minute.
Yeah, yeah.
Can we have Obiram, please? Yeah. Obiram, we are with you. Obiram?
It's my needle. Can you hear me?
Yes, we can hear you.
We are showing the needle where through which the
So
marker
this
will
is
be
a
placed in
marker
the-
placement. Yeah. Yeah.
And the marker should be in the center of the lump. So we have assessed the lump size. It's around 6 centimeter. So I will pierce about 3 centimeter through this lump. Here is the marker. So it's almost.
So how
in the
many
center.
markers do you routinely put, Obiram?
One.
One. Because there are two schools of thought. One believes in putting a marker on either side of the lump,
Yeah.
and the majority prefer to put one in the heart of the tumor. So you belong to the second group, I assume.
Yeah.
Okay.
What? Okay. It has done already.
Okay. Thank you, Obiram. Can we go back to the other?
Yeah,
OT,
you can
please?
go back to the thyroid.
Thank
surgery.
you.
Our procedure is over. Thank you.
Thank you.
This is the isthmus. This is the isthmus you have taken. The isthmus. There is no enlargement in the isthmus. So,
সরে যাচ্ছে আপনারা নিন না।
The gauze out of this one, give me a gauze piece. Put it there.
Sir, could you see any or both of the parathyroid?
Yeah.
Could you show it to us, please?
Yeah. So this is the upper pole. You can see the parathyroid.
Zoom, please. Can you zoom in, please?
This one. Yeah.
Right, sir.
Yeah. We have leave behind the superior
Yes.
parathyroid there.
So this is the superior one, right,
And
sir?
you see, this is a recurrent nerve coming
Yes,
here.
yes.
And this is a Berry's ligament. So you should be very careful again in the Berry's ligament that you don't injure the recurrent nerve.
And particularly if there's a hemorrhage there, we have to be very careful
Hold
with
it,
our energy
hold,
sources.
hold. You could somehow manage without a ligature. All the pedicle you could take with the bipolar. Yeah. So this is the lobe and this is the area of the isthmus. Okay. So
Sister, can you show us the specimen, please?
yeah.
Siddharth? Siddharth, can you bring the specimen into the view, please? Yes. Can you zoom in, please, camera person? Yeah. So this is the left lobe. And yes, that's the isthmus. Right.
Achha,
Thank
actually,
you. Thank you. Yeah.
what I do is I just do a Valsalva
Yes,
to
sir.
see if there is just give saline. Madam, ekto na valta close kore. Din sister din. Keep it here. Push, put. So there is no bleeding as such. I'll ask the anesthetic the Valsalva. If there is a minor ruse, this will come up. Okay. If not, we'll assume that there is no bleeding. Okay, sister. Give me a white. Yeah, this one. देखो दिखा दो नहीं नाम की दो ये सुबह दिखाया थे ये ना पाइपलाइन देखिए सील कर रहा है
So what are you just achieving hemostasis or are you sealing the midline with the sealer?
This I could find out in one of the presentation.
Right,
They are just using bipolar to oppose the muscle instead of suture.
So there's sutureless in the truest sense. But does it hold good, sir? Well, I don't know. I have not seen this before. Does it hold good or does it come off later?
This I could find out while going through some videos.
Right, sir.
You see, it's sealed.
Because when we say sutureless thyroidectomy, it usually means that we use no suture in the pedicles. But I didn't know whether the muscles could also be brought forward without a suture.
No drain. So much opposition is not recorded. Chodo. George chodo. The idea is just to oppose, not to
Right.
strangle.
Right, sir.
Okay, so it is just opposed, no problem. So inside is a very good hemostasis. So again, the putting drain in thyroid is not mandatory. Okay.
So we have quite a clean field now. So I don't think a drain will be necessary.
Yeah. Monocril. So Dr. Siddharth will apply a layer in the monocril 30.
रिवर्स ब्लीडिंग होते पाए ना सर
हाँ अभी देख लिया भाषा कर लिया अगर भाषा नहीं होगा तो बाद में होगा तो पैरालाइज दिखेगा आप क्या करें
So you'll be using monocryl for the platysma.
इतना ड्राई है तो नहीं करता है हाँ अभी देखो सारे तो फिसल निकल गया अभी अंदर कोई डायलेट फिसल नहीं है
So you'll be using monocryl or vicryl for the platysma?
Monocryl.
30 monocryl?
Yeah.
Okay.
देखो Thank you.
Thank you, sir. Thank you.
Yeah. Nini, local media.
Thank you very much, sir.
Thank you.
Before concluding, I would request to Mr. Anup Sharma, will you please arrange for the vote of thanks?
नहीं हमारे थैंक्स हमारे दिते দাও আগে এই নিকালে ভাই
Hello.
Actually, we did not think that things will go so smooth that we finish it by 2 p.m. Otherwise, you could have little more cases. So I must thank all the centers of different medical colleges, particularly the head of the departments, who has taken the trouble of making some arrangement for this live viewership. And I must thank Alkem Laboratories Guardian Division. They have taken initiative, and in very short time, they have been able to arrange all the logistics. So I hope you have enjoyed the program, and this gives us some hope that even a state conference can have some good workshop, and this can be made all India transmission. So I must thank everyone who have viewed us from the morning, and it's our pleasure to present just a glimpse. You cannot cover a wide number of cases, but still this is an effort on our part. So Mr. Sharma is around.
Sir, I would be taking this. Myself, Bhalchandra Joshi. Thank you, sir.
Yeah.
Thank you. Thank you, sir. Hello, good afternoon to one and all. Myself, Bhalchandra Joshi, and I'm marketing head with Burjan Nova division, makers of Joseph, Enzoplam, and Oxum. At this outset, I take this opportunity to thank the organizing committee of Sasicon 2021 for giving us partnering opportunity for this exclusive live surgery workshop. And also special thanks to Dr. M.L. Shah, sir, President is ASI WP chapter, and faculty for this workshop, Dr. Abhiram Maji, Honorable Secretary, ASI WP chapter. Also special thanks to Dr. Om Tantia and Dr. Tamunas and ILS hospital team for opportunity to get associated for this wonderful academic feast. Our expert surgeons who relentlessly performing surgeries, Dr. M.L. Saha, Dr. Diptendra Sarkar sir, Dr. Om Tantia sir, Dr. Tamunas sir, our esteemed moderator panels, and all the dignitaries of WBASI chapter. Sir, with 2,800 plus registrations and 2,400 live audiences, I would also want to extend my thanks to all the HODs, professors of 27 centers across medical colleges where this webinar streaming is live. And I'm sure this webinar is enriched all the audiences with important tips and tricks of various laparoscopic surgeries. And of course, sir, your valuable prescription support is encouraging us as always. Thank you and have a pleasant evening. Thank you. Thank you. Thank you, sir.
Thank you, sir.
उनका कैमरा आया ही नहीं, उनका ब्लैक कैमरा आया। हाँ होटल थैंक्स, अच्छा मीटिंग चालू है, खत्म हो मीटिंग चल रहा है, खत्म हो गया ठीक है। उनके लैपटॉप में कुछ प्रॉब्लम था।
Finish it. Yeah, stop कर सारा. Everything is stop. Okay. So already your vote of thanks has been given. Okay.
Recording stopped.
It's over. Finish over, na? Thank you, sir. Thank you so much. Yes. তুমি মানে আমাকে পাতাই দিচ্ছ না আজকে আমার একটা ছোট